Hello, everybody. Welcome to the LRR session of OBS Gynae with Prep Ladder. I am Dr. Shonali Chandra, your OBS Gynae faculty, new faculty from Prep Ladder. I welcome you all to this session. So, while we're waiting for people to join in, and let me read your comments as well. Good evening, everybody. Good evening for those who have joined in. Yes. Yeah, let me just go through this too. Good evening, good evening. Good evening, everybody. Right. So there are certain questions regarding where to access the PDF from. Well, I think these are just basically mainly high yield PYQs that we are going to be discussing, because since this is the last minute rapid revision, so this is going to be a quick recall of high yield PYQs from the recent examination. So I've chosen those questions which are going to highlight the important previous year topics for you people as well. So that is most important, all right. Other than that, when you'll go through the new content on the version X, you will also find the rapid revision videos that I have made. Okay, now in my rapid revision videos, you will find that all the one-liner important previous year pointers from the questions. Also in the rapid revision only, we have also incorporated MCQ based rapid revision, so that is going to be an added plus point. Okay, so along with that, if you go through with this high yield revision, it is going to be beneficial, right? So yes, all right, we will take up all your queries, all your questions and everything. And if there are any further topics also, see, we're going to have a discussion for 2 days back, back to back, right? So there's today, there's tomorrow, so that is not going to be an issue. All right. No. Yes. All right. So yes, I'm getting a lot of your comments and everything, and there's certain queries regarding where the PDFs are going to be and everything. So yes, we can provide the PDF after the discussion also, so that is not going to be a concern. I'm sure the team will take care of that. Okay. All right. Okay. Yes. All right. Now, is it for FMG or NEET PG? That's a very valid question. See, whatever it is an exam. OBS Gynae is going to be covered, and don't worry about whether I'm going to be discussing clinical questions and everything, because it is going to be important whatever type of exam you have. But yes, my quite a lot of focus is also going to be on the upcoming INI CET as well. Okay. Yes. The session is going to be at least 2 hours long. Okay, so let's begin now. Let's I think all of you have joined in, so let's begin now. So let's have a look at the first question. Okay, this is your first example question, a recent MCQ, and then we're going to highlight the important pointers. So patient came to the gynae OPD with complaints of foul smelling, frothy vaginal discharge and intense itching. On examination, the cervix was spotted and had the appearance of a strawberry. Identify the causative organism. Yes, excellent. Everybody quickly answering Trichomonas vaginalis. All right. So when we say Trichomonas vaginalis, is this a sexually transmitted infection or not? Yes. Is this a sexually transmitted infection or not? Yes or no? Yes, it is a sexually transmitted infection. All right. Now, also remember here, since it is a sexually transmitted infection, partner treatment is going to be a must. Partner treatment is going to be a must. What is the treatment of choice going to be? Yes, what is the treatment of choice going to be? What is the drug of choice for Trichomonas vaginalis? Yes. Excellent. Yes, metronidazole. Metronidazole group of drugs is going to be the drug of choice. All right. Now, among these options, which of these is not a sexually transmitted infection? Which of these is not a sexually transmitted infection? Among the options in the question, which of these is not a sexually transmitted infection? Yes. Candida. Some people are saying Candida. Okay, and some people are saying Gardnerella vaginalis. Both of you are correct. So Candida, and if you have to pick one, it would be Gardnerella vaginalis if you have to pick one. Okay, so Gardnerella vaginalis is the agent that we associate with bacterial vaginosis. Now, bacterial vaginosis is definitely not a sexually transmitted infection. It is just alteration in the microflora, right? So that is what it is. Bacterial vaginosis is definitely not a sexually transmitted infection. Candida could be transmitted sexually, but usually is not a sexually transmitted infection. Okay, so Candida, I would say, usually not a sexually transmitted infection, but potentially could get sexually transmitted as well. Excellent. So let's have a look at this flow chart. It will help you remember. Let's have a look at this flow chart. It will help you remember. You have a woman coming with the complaint of vaginal discharge. Okay. Now, the first thing that you do is do a per speculum examination and then, proceed with the per vaginal examination. If on per speculum examination, you see that the discharge is coming from the vagina and the cervix is given to you absolutely healthy, you're looking at a clinical diagnosis of vaginitis. Okay. Then look at these pointers. If you have a milky white discharge given to you, fishy odor, no itching, pH more than 4.5, clue cells are present on the wet smear, whiff test is positive. What is it? What are we looking at? We are looking at the diagnosis of bacterial vaginosis. Okay. If they tell you that there is a curdy white discharge, if they tell you there's a curdy white discharge with intense itching, dysuria could be there. pH less than 4.5. There's one organism that can grow in acidic vaginal pH also. On the saline microscopy, you can see the fungal pseudohyphae or budding yeast cell. WBCs can also be seen. Excellent. That is Candida. Okay. And if they tell you, yes, greenish, frothy discharge, foul smelling, itching, strawberry cervix, pH more than 4.5, they may mention that there is a flagellated microorganism with a tennis racket appearance, all right? And WBCs are seen, whiff test is positive. It is trichomoniasis. It is trichomoniasis. An excellent, Shan, I read your answer there. You're the first one who pointed out for bacterial vaginosis, this clinical criteria of diagnosis, which includes whiff test, which includes clue cells, which includes the characteristics of the discharge, which includes the vaginal pH. Excellent. It is Amsel's criteria for bacterial vaginosis. Excellent. Amsel's criteria for bacterial vaginosis. Now, let's come to the other side of the flow chart. If they tell you in the question that there is a discharge coming out of the os, if they tell you that the cervix is looking unhealthy, they may give you the information that the cervix, may be hypertrophied, maybe there's some mucoid discharge on the cervix. They may tell you that the cervix is bleeding on touch. They may tell you that there's cervical erosion. You're looking at the clinical diagnosis of cervicitis, right? Now, when you are looking at the cervix on per speculum examination, now would be a right time to at least take, an endocervical swab sample. Before doing a PV, take an endocervical swab sample. If there's a discharge, you can take the sample of the discharge also, okay? And then, important thing is you can subject this, specimen to certain lab tests. Okay. Now, yes, of course, when you are looking at cervicitis, you're thinking about chlamydia, you're thinking about gonorrhea. Okay. And yes, the investigation of choice, whether for chlamydia, whether for gonorrhea, the investigation of choice, if it's a blanket question, if the investigation of choice is nucleic acid amplification tests, I agree. But many times, especially when we're talking about the syndromic approach and when we're talking about low resource, conditions and settings, we may not have access to these nucleic acid amplification tests. Then we can go ahead and do a gram stain also. Okay, so a gram stain of the endocervical smear if you have taken, and if you find WBCs and no organisms are seen, we can make a presumptive diagnosis of chlamydia. If WBCs are seen and they tell you that gram-negative intracellular diplococci are seen. So understand, my dear friends, that this is how they, tend to integrate microbiology into your, obs and gynae, right? So they give you this information that WBCs are seen and gram stain is showing intracellular diplococci. Your presumptive diagnosis is of gonorrhea. Okay, and then in that situation we can treat for cervical discharge, we can treat for cervicitis, right? So very important pointer. Now NACO kits, okay, these are must know. Recently they've been consistently asking you questions on NACO kits, right? So I remember kit 1 here, have a look. Kit 1 is for cervical discharge. Okay, I remember kit 1 as cervicitis, okay, as cervicitis. I remember it as cervicitis, and I remember gonorrhea, okay, and with that I remember it as G. So gray colored kit is kit 1, is for cervical discharge, okay. The green colored kit is kit 2, it is for vaginal discharge. I remember it as vaginitis. I remember the green colored discharge of Trichomonas vaginitis. So green colored kit is for vaginal discharge, vaginitis. You can see here it has secnidazole also, it has fluconazole also. Okay, so secnidazole takes care of bacterial vaginosis, takes care of trichomoniasis. Fluconazole takes care of candida, right? So this is the syndromic approach to treatment of vaginal discharge. If you have this, kit 6 given to you, yellow colored kit, I remember P for pus cells. I remember P for PID. I remember the yellow color of pus. So the yellow colored kit is your kit 6. It is for PID, OPD based treatment for PID and lower abdominal pain. You can see here it contains cefixime, metronidazole as well as doxycycline. Okay. Now Iman Chaudhary, you are mentioning that bacterial vaginosis diagrams from gram stain only gives a Nugent score from 1 to 10. Excellent. Yeah. So gram stain is the gold standard, they say, for diagnosis of bacterial vaginosis. But do we really all the time do gram stain for diagnosis of bacterial vaginosis in clinical practice? No. So gold standard test for one-liner questions, yes. But gold standard test may not always be done in clinical practice. Make a note of that. So yes, you can add that extra point here also. Gold standard for bacterial vaginosis is Nugent scoring on gram stain. Excellent for pointing it out. Very nice point you made there. Very good. Okay. So when we are treating, coming back to this, there are two more important pointers regarding the kits still left. When you're treating for syndromic, treatment, when you're doing the treatment with kit-based treatment, then you always have to treat the symptomatic partner also. And when we are doing kit-based treatment for lower abdominal pain, then the symptomatic partner has to be treated with kit 1. Okay, so remember these extra bits, these are extra pointers that you should make a note of for your exams. All right, clear? Okay. So let's move on to the next question. So this was a quick recall of the vaginitis, the cervicitis and the syndromic approach treatment based on NACO kits. All right. Moving on, let's have a look at, okay, before that, also tell me, if I were to ask you bacterial vaginosis in pregnancy, what would be treatment of choice be? Bacterial vaginosis in pregnancy, what would be the treatment of choice be? Excellent, Dr. Collagen and Dhananjay, erythromycin, clindamycin, metronidazole. But clindamycin is definitely an alternative drug for bacterial vaginosis. Bacterial vaginosis, we have discussed, drug of choice is metronidazole group of drugs. Even in your kit 1, even in your this thing here, it is secnidazole from the metronidazole group of drugs only. Alright, so don't get confused. Clindamycin is definitely an alternative drug. I don't deny that. But if treatment of choice is asked, it is metronidazole only. Okay. Please, it is metronidazole. In the first trimester, you would not want to give oral metronidazole. You can give vaginal route. You can give vaginal route. So it's not complicated. You don't have to mug up any other drug. It is the same. It is just that in first trimester, vaginal route is going to be more preferable. That's all. Okay. So if a woman is symptomatic in pregnancy, you treat it. Treat symptomatic women in pregnancy with the same regimen, but just that in first trimester we would prefer the vaginal route. Same goes for trichomoniasis also. You have to give metronidazole first trimester. If it is, then you can't give oral. Do not prefer oral. Give vaginal route. Okay. And what about candidiasis in pregnancy? What about candidiasis in pregnancy? Yes. What about candidiasis in pregnancy? How do we treat that? In first trimester, what do we do? Clotrimazole. Clotrimazole vaginal pessary. Clotrimazole vaginal pessary. See, fluconazole is contraindicated. Fluconazole is contraindicated. I won't use fluconazole. Okay, थोड़ा सा हिंदी में भी बोल लेंगे. English कर लेते हैं इसको. For if the majority people want it in mix. चलो. Yes. So if candidiasis in pregnancy, fluconazole is contraindicated. लेकिन देना अजोल ही है, तो clotrimazole we will give vaginal pessary. Okay, fine. चलो, good. So a lot of you people writing topical clotrimazole. Good, topical clotrimazole is the answer. चलो, next question. A 35-year-old sexually active woman visits the gynae OPD for routine checkup. She is concerned because her mother died of cervical cancer at the age of 40 years. What would you advise to her? HPV vaccination, cervical cancer screening, BRCA testing, or HNPCC testing? Yes. Let's see your responses. So somebody is saying, a lot of you people are saying option number B, cervical cancer screening. One of you said C, which I would say BRCA testing. See, cervical cancer is one cancer, my dear friends, where you don't learn about anything about genetics, okay? No genetic risk factors you mug up there. This BRCA, you read about BRCA for breast cancer, you read about BRCA in ovarian cancer, okay? You read about HNPCC, the Lynch 2 syndrome. You read about this where? In hereditary non-polyposis colon cancer syndrome. So HNPCC you read in colon cancer. You read about it in endometrial cancer, ovarian cancer, right? So these are anyways out. They're unrelated. Okay. Now for this woman, had a mother had a history of, ovarian cancer at a young age, endometrial cancer at a young age, then doing BRCA testing and HNPC testing would have made sense. Her mother died of cervical cancer at the age of 40 years. What options are there? She can get vaccinated, but it is too late now. She is already 35-year-old. This is not a primary age group for cervical cancer vaccination against cervical cancer. So vaccination is out. The only option left is now cervical cancer screening. Okay, the way we prevent cervical cancer in women, there are two ways we prevent cervical cancer in women. One is vaccination. The second is early diagnosis and treatment of pre-malignant lesions of the cervix, and that we do by cervical cancer screening and then working up there, screen test positive and then further steps. Okay. So the answer here is cervical cancer screening. Now what you need to remember here is they are asking you a lot of questions regarding cervical cancer screening also and regarding HPV vaccination. So first important point is regarding HPV vaccination. This is a must know area. Okay, so the vaccines that we are using nowadays, okay, one is Gardasil, one is Cervavac. Okay, the only difference between the two is one is Indian made, right? This is the Indian made Cervavac from the Serum Institute of our country in Pune, and Gardasil is the foreign brand. Okay, they both are quadrivalent vaccines. So when I say quadrivalent, that means they have HPV 6, 11, 16 and 18. Okay, so HPV 6 and 11 are the low risk types. They are the low risk HPV DNA types. Okay, so there is protection against warts also because they cause warts. Okay, so this is for warts, anogenital warts. HPV 16 and 11, they are the most common high risk HPV DNA types that are associated with cervical cancer as well as CIN. okay, as well as CIN. So, if you have to pick one among the two, both together, 16, 18 together, they're responsible for 70% cases of cervical cancer. But if you have to pick one out of the two, then you pick HPV 16 as the best answer, all right? And then we have this Gardasil 9, which will contain the above 4 strains as well as 5 additional high-risk HPV DNA type strains. It is very important to remember that it is an inactivated vaccine made up of the L1 viral capsid protein. Okay, L1 viral capsid protein. Now, there's a question by Harjeet, the recommended age group is 9 to 45, then why not vaccination? So, the recommended age, my dear friends, is actually 9 to 26, right? And the best protection from vaccination would be obviously in women who have not yet become sexually active, because HPV vaccination is HPV infection is very, very common. Whosoever is getting sexually active will somewhere in their lifetime acquire HPV infection. It is that common, right? So please remember here that the target age group, these are vaccination schedules. So we have a target age group in our country, and that is 9 to 14 years of age. You want to इसको और कम कर दे, टारगेट एज ग्रुप को थोड़ा और कम कर दे तो 11 to 12 years. Okay, target age group is 9 to 14 years. Okay, those young girls who are still adolescent, जिन्होंने अभी तक अपनी सेक्सुअल एक्टिविटी शुरू नहीं करी है. ठीक है, बियॉन्ड 15 years ये बोलते हैं कि भाई 14 years के बाद जो है हमारा कैचअप वैक्सीनेशन चलेगा, कि भाई जिनको पहले नहीं लगा उनको लगा देंगे. ठीक है, फाइन. सो 26 बियॉन्ड ये 14 to 26 years पे हम लोग क्या कर रहे हैं, कैचअप वैक्सीनेशन कर रहे हैं, कैचअप वैक्सीनेशन कर रहे हैं. ठीक है, अब 26 के बियॉन्ड द एज ऑफ 26 years सर्वाइकल कैंसर वैक्सीन केस टू केस बेसिस ओनली हाई रिस्क, क्योंकि वो कह रहे हैं कि वैक्सीन की एफिकेसी में नॉट बी दैट गुड. Okay, so beyond 26 years is only case to case basis. And like you said कि भाई ये कौन सी यूज कर रहे हैं, भी दोनों में से पॉइंट ये है कि वो कॉस्ट का ही डिफरेंस है. वेरी राइटली सेड, प्राइस डिफरेंस प्रथमेश, एक्सीलेंट, वही फर्क है कि प्राइस डिफरेंस में पेशेंट कौन सा अफोर्ड करता है. अब डोसेज शेड्यूल क्या है, डोसेज शेड्यूल फ्रॉम 9 to 14 years of age it is 2 doses are given. Okay, and बियॉन्ड 15 years it is 3 doses. ठीक है, 2 dose मतलब एक 0 और एक 6 months पे. ओके, फिर 3 dose में 0, 1 और 2 months और 6 months पे. ठीक है, करंटली जो हमारा गवर्नमेंट ऑफ इंडिया का शेड्यूल है वो यही है. ठीक है, करंटली जो गवर्नमेंट ऑफ इंडिया का डोसेज शेड्यूल है वो यही है. बीच में एक INI CET में क्वेश्चन आ गया था सेज रिकमेंडेशंस का, WHO की सेज रिकमेंडेशंस का बीच में INI CET में क्वेश्चन आ गया था. वो तब आया था बिकॉज एट दैट टाइम WHO हैड मेड अ रिकमेंडेशन कि वी कैन डिक्रीज द डोज बिटवीन 9 to 20 वी कैन गिव 1 or 2 doses, बिटवीन बियॉन्ड 21 years वी कैन गिव 2 doses. हम डोज कम कर सकते हैं, राइट. ये स्टेज रिकमेंडेशंस अभी गवर्नमेंट ऑफ इंडिया गाइडलाइंस में या ये जो हमारा इम्यूनाइजेशन शेड्यूल है उसमें दे हैव नॉट बीन इनकॉर्पोरेटेड. ओके, फाइन. सो करंटली दिस इज द डोसेज शेड्यूल. ओके, नेक्स्ट क्वेश्चन, वैक्सीनेटेड women should they be screened or not? Vaccinated women should they be screened or not? Yes, very good. Vaccinated women, they still need to be given the vaccine. Okay, they still need to be screened. Okay, can sexually active women get vaccinated? Can sexually active women get vaccinated? Yes or no? Can they get vaccinated, or you say okay, you are already sexually active, it is not okay, you should not get vaccine? No. Okay, so yes, sexually active women can also get vaccinated. HPV testing, should it be done before vaccination? Is it done before vaccination? Okay, let's check the HPV status and then we will decide whether to give you vaccine or not. No, right? So HPV testing before vaccination, no, it is not done. Yes, no. No is the answers. HPV testing before vaccination is not recommended. Can we give the vaccine to pregnant women? Yes or no? Can we give the vaccine to pregnant women? Yes or no? No. Okay, even though it is an inactivated vaccine, yet the vaccine is not to be given in pregnant women. So don't get confused. Okay, so even though it is an inactivated vaccine, let me remind you, it is not recommended to be given to women who are already pregnant. If accidentally we have given to pregnant women, then it's not an indication that, oh, we have given vaccine, let's do MTP. Not like that. If accidentally we have given one dose, then we will not, at least continue it further. We will continue the dosage schedule after her pregnancy is over. Okay. So we should not give it to pregnant women. That's the bottom line. Okay. All right. Now, let's have a look at the next question regarding cervical cancer screening. Which of the following is true regarding cervical cancer screening in low resource settings? Very recent question from your most recent. Yes, waiting for your responses. Which of the following is true regarding cervical cancer screening in low resource settings? Co-testing, pap smear, HPV DNA testing, starting at age 30, starting at age 25. So these are the sort of questions that they've been asking from screening, and I'm telling you why they're asking you this question also, because recently, WHO also, updated its recommendations regarding cervical cancer screening. So that is the reason why this has become a hotshot topic nowadays. Okay. So co-testing is when we are doing HPV DNA testing as well as pap testing in the same patient for screening. Okay. Together we are doing, that is co-testing. Okay. So co-testing can be done, but it is not going to be cost effective, isn't it? It is going to be for high resource settings because we are doing 2 tests. So this is out. All right. Pap smear testing should be done every 3 years starting at age 21. This is correct. But again, pap smear is also resource intensive. You will need a path lab and you will need a pathologist to review the pap smear and everything. So pap smear is not for low resource setting. Now, low resource setting, there are 2 things that can be done. One is the visual inspection with acetic acid. VIA testing is also there. VIA testing every 3 years is also recommended in low resource settings. Okay. And then the recent WHO is saying that we are also now, focusing on HPV DNA testing. Okay, and low cost point of care HPV DNA tests are also available, and they can also be used in low resource settings. Okay, so HPV DNA testing every 5 years starting at age 30. If whenever you have to screen with HPV, it has to be from age 30 onwards. Okay, HPV DNA testing is not done as a method of screening in younger women, not below 30 years, even when we do co-testing. In co-testing also, HPV DNA testing is a part of co-testing. Co-testing also starts at age 30. Okay. So HPV DNA testing also starts at age 30, not at age 25. So option number D is also wrong. Your correct answer is option number C. All right. Remember these important points. Okay, and catobase, you made a very nice point here. Acetic acid would be very good. Visual inspection with acetic acid would be, in our context, in the Indian context, it would be even cheaper than HPV DNA testing. You are correct there. It would be the cheapest because all you need is a speculum, white light torch, and the acetic acid solution. So you are right there. Very nice point there. Okay. Very nice point there. Now, let's have a look at the next question. Again, So now see, in the recent examinations, they've started asking you about identification of cervical cancer, screening for cervical cancer. That is where they're focusing on. That is why I have 3 questions here for you. So 46-year-old woman complaint of post-coital bleeding, which is a very specific complaint of cervical cancer. To be very precise, post-coital bleeding is sort of a contact bleeding. So post-coital bleeding is telling me that there is some lesion on the cervix. To be very frank, that is what it is telling. And she is found to have cervical erosion on pars speculum examination. What are the most appropriate steps undertaken? Now, this is a simple question. The only thing that you need to know here is postcoital bleeding. There's possibly something on the cervix. That something could be cancer, and that something could be cervical cancer, or a pre-malignant lesion of the cervix. It could be CIN. These are the 3 points that you know to attempt this question. HCV DNA testing has got nothing to do with it. Hepatitis B testing has got nothing to do with it. HIV testing has got nothing to do with it. Right? So the best answer is you need some sort of cervical cancer screening in place to begin with, isn't it? They are telling you that the cervical erosion is seen. They are telling you cervical erosion is seen. They are not telling you that there is a growth on the cervix. If there was a growth on the cervix, you would have biopsied the growth. If you're seeing a growth, you would biopsy the growth, isn't it? But they are telling you there is some cervical erosion. So now you're not sure. So at least do the screening. Right? So liquid based cytology, LBC is liquid based cytology. A way to take pap smear, a way to process the pap smear, a way to process the cytology. HPV DNA testing makes sense. It makes sense to do these screening tests. If there is something abnormal in them, yes, we can go for a cervical biopsy also. So this is the best answer to choose. Not option B, my dear friends. Okay. So answer is option number D. So half of you got it correct. I would say roughly looking at your options, half of you, right? So erosion, Aditya, lesion is visible. Aditya, I read your comment. Cervical erosion. Erosion is not a lesion. It is cervical erosion, cervical ectropion, one and the same thing. It's not a lesion. Cervical erosion will not be counted as a lesion, right? But please remember, LBC, HPV DNA testing is cervical biopsy, depending upon whatever is the initial report of the screening test telling us. So that would be the answer. So let's understand here. Let's just summarize it. Okay. Let's summarize it. When you have a woman with the complaint of postcoital bleeding, okay, start with a just a second. Let me just highlight your comments a bit. Yeah. Let's summarize once and for all. When you have a complaint of postcoital bleeding, start with a pars speculum examination. Okay. Now, if you're seeing a visible growth, they will tell you that there is a visible growth. Okay. Now, what sort of things they will tell you about visible growth? They will tell you ulcerative growth, fungating growth. Okay. They may tell you that the cervix feels hard, nodular to feel, like that. So something specific will be given to you, right? Then you take a punch biopsy, cervical punch biopsy. Okay, fine. If on pars speculum examination they tell you nothing is there, normal, and I'm telling you cervical erosion, ectropion are pretty common in reproductive age group women. So if they tell you nothing is there, if everything is normal, at least do some cervical cancer screening test. Okay, at least do some cervical cancer screening test. Don't forget that. Okay, now also make it a point. If you have any abnormal cervical cancer screening result, okay, or there is a suspicious looking cervix, then tell me now, Tell me now, what will you do? Tell me now. Tell me now, what will we do? By the time you are answering, I will just answer this question by Philip. Philip, HPV DNA testing is not to be done in below 30 years. If below 30 years, I really want to screen a woman, I will do cytology. Cytology is the option. अरे फिर biopsy, you better answer to choose biopsy. चलो ठीक है, I will say okay. But before biopsy, you need the most abnormal looking area to biopsy. So better answer is go step by step. Better answer is go step by step, do colposcopy. Colposcopy. Okay, and people who are writing colonoscopy, I think they wanted to write colposcopy only. So colposcopy, right? Colposcopy will help you analyze the suspicious area also under magnification. Okay, abnormal screen test, look at the cervix under magnification after applying acetic acid, look at the abnormal area to biopsy, most abnormal area to biopsy. So, colposcopy will be done next. Okay, let me add more to this situation. Let's say you had a normal cervix. Let me add more to the situation. Normal cervix, normal screening, everything normal. But her postcoital bleeding complaint persists. What now? You did what was needed initially. Normal cervix, normal screen, postcoital complaint bleeding persist. What now? What now? What now? Yes. What now? Again, interesting answers I am getting. Colposcopy, some of you are saying conization. Conization is a very dramatic procedure. Why would you want to directly go ahead and remove a cone of the cervix completely? Endometrial biopsy, okay, endometrial biopsy, and estrogen cream is an interesting choice of options. And okay, screening is not 100% all the time. Do you agree with me? Every screening test has a, false positive, false negative and all that, okay? So, screening is not going to be 100% all the time. You should go ahead and do a colposcopy. Don't forget the cervix. In Indian context, cervical cancer is the most common gynae cancer in Indian women, right? So, best answer to choose would be a colposcopy. And for the ones where you're saying topical estrogen, yeah, before you give any treatment, ensure that there is no cancer. Topical estrogen will make sense. You are right, because it will make sense if there, you have findings of atrophic vaginitis and you have ruled out everything else, then of course, estrogen cream will make sense, like you said, okay? So, colposcopy would be the answer. And for the ones who were saying endocervical curettage and endocervical curettage is always a part of colposcopic evaluation, biopsy, ECC we also incorporated in that. So, when we evaluate the cervix, we evaluate the ectocervix also, endocervix also. Okay, so it often becomes a part of your endocervical curettage, often becomes a part of colposcopy guided biopsy plus endocervical curettage we tend to do. Okay, now for those of you who were saying endometrial sampling, okay, please understand, let's just put it here. If there was intermenstrual bleeding or heavy menstrual bleeding, something to suggest that there may be a lesion inside the uterus, okay, then of course one would also perform transvaginal sonography and then decide whether or not endometrial aspiration is needed. So, first transvaginal sonography and then decide accordingly whether or not endometrial aspiration, endometrial sampling is needed or not. Because the reason why you are doing endometrial sampling is for ruling out endometrial hyperplasias and cancer. They generally will not present with postcoital bleeding. I am telling from the very beginning, I told you postcoital bleeding is something specific on the cervix. Okay. right? All right, chalo. So this is summarizing the entire postcoital bleeding scenario. Okay, let's move ahead with the next question. Again on cervical cancer. 37-year-old woman with irregular vaginal bleeding is diagnosed with cervical cancer. She has a 4-centimeter growth over her cervix and left-sided hydronephrosis. What is the most appropriate treatment? You also have to tell me the stage for this patient. Okay, one is this question with 4 options, additional question. Also tell me the stage. Maulik, your question will be answered in a while. There are more questions to follow. Yes. Stage 3B. People are writing stage 3B, 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 3B. Excellent. Majority of writing 3B. It's not the 4th stage. 4th stage is distant metastasis. 4th stage is distant metastasis. 4th stage is bladder and bowel, right? So this is left-sided hydronephrosis. That means your clinical clues. It means it has gone to the lateral pelvic wall. It has gone all the way up to the lateral pelvic wall. Because what is there in the lateral pelvic wall? The ureter is there in the lateral pelvic wall. Right? They could also tell you that there is, sciatica-like pain. They could tell you there is sciatica-like pain. Why? Because there are pelvic nerves in the lateral pelvic wall. They could tell you that she has lymphedema, swelling in the limbs. Why? Because the lymph nodes and the lymphatics and everything, that is in the lateral pelvic wall. So the moment they tell me that there's left-sided hydronephrosis, there's sciatica-like pain, lymphedema, clinically I can understand. Clinically I can understand that it has gone all the way up to the lateral pelvic wall. Okay, so when it goes all the way up to the lateral pelvic wall, it is stage 3B. So you're right, it is stage 3B. And now you are right if you say that the answer is chemoradiation. Yes, right? So remember one thing, chemoradiation, the moment it is stage 2B and beyond. What is stage 2B? 2B is parametrium. 2B is, what is stage 2B? Parametrium involved, but not up to the lateral pelvic wall. Not up to the lateral pelvic wall. That is stage 2B. The moment it is stage 2B and beyond, treatment of choice is chemoradiation. Okay. The moment you see bulky growths. What are bulky growths? Remember here, more than 4 centimeter growth. 1B3, 2A2. This is a very, quick way to remember the staging also, the most critical things about staging. 1B3 is growth on the cervix, but the size is more than 4 centimeter. 2A2 is, it is reaching the upper part of the vagina, the upper 2/3 of the vagina, but size is also more than 4 centimeter. The moment you see bulky growths, it is chemoradiation. Okay, so the treatment of choice is chemoradiation in these situations. Okay, radiotherapy alone can be given if chemo is not being tolerated, if chemo is not available. Okay, the primary treatment of cervical cancer, mind you friends, the primary treatment for cervical cancer is radiotherapy. The chemo part in chemoradiation acts as a radiation sensitizer. So chemo alone, not an option. Radiotherapy alone can be an option. Best option, chemoradiation. Chemo part is radiation sensitizer. What is the drug of choice? Cisplatin is the drug of choice. Cisplatin is the drug of choice. Excellent, Nikhil. Okay, right? Now your Vardheim's hysterectomy, your radical hysterectomies, they are limited to early stage cervical cancers where you have the growth that is limited to the cervix. Okay, clear? Fine. All right. So stage 2B, beyond stage 2 तो बता दिया, stage 3B भी बता दिया. Staging में तो staging is already covered. Stage 3B is all the way up to the lateral pelvic wall. Stage 3C is pelvic and or para-aortic lymph nodes. Remember this. Okay, these are the most important points regarding staging that you need to remember. Now, next question. Okay, let's just take a break from cancers. Let's move to amenorrheas, another hot topic, especially for your INI CET, upcoming INI CET, FMG. People are also now asking you questions on amenorrheas. Okay, and these are all previous year questions, but very interesting. I may have tweaked your questions a little bit just to make them more comprehensive. Okay, now 30-year-old para 3 live 3 woman comes with complaint of amenorrhea for 9 months. 3 months ago, she had undergone a curettage for missed abortion. There is no withdrawal bleeding on progesterone challenge test, and the physical pelvic examination is normal, UPT is negative. See, whenever you read my questions, dear friends, always understand what all the questions, extra information the question is giving you. The question is telling you that you have a woman with amenorrhea, okay, you should always rule out pregnancy. That is also what this question is telling you. Let me make it very clear. Remember this. UPT is negative. Progesterone challenge test was done. She was given progesterone for 5 days. That is what progesterone challenge test means. We give progesterone for 5 days. See if she has a withdrawal bleed. There is no withdrawal bleed. Then her serum FSH levels must have been tested. And the report is given to you, 7 international units per liter. What is the most likely diagnosis? And you can attempt and should be able to attempt this question even if you have no idea about what normal serum FSH levels actually are. Normal serum FSH levels is a very wide range. Broadly, yes, anything between 5 to 20 international units can be considered as normal. So that is my clue to you. And so Aishwarya, I think now you will know. You've chosen option D as the answer. And those of you who've chosen option D as the answer, now you will know that it is not premature ovarian insufficiency. If premature ovarian insufficiency would have been there, then FSH would have been elevated. Okay, right? If pituitary failure would have been there, FSH would have been low. All right, this is normal. So now you know the answer. It is uterine synechia. The biggest clue, curettage. Why are you missing on the chronology of events? Curettage. All right, she's para 3, live 3, she had 3 children, and then, curettage happened. And it is, the sequence of events is such that she's not had a period after that. Right? Progesterone challenge test was done, it was negative. There's no withdrawal bleed. With PCOS, whenever the estrogen levels are normal, there is no estrogen deficiency. There is no estrogen deficiency. Okay. Endometrium is normal. Then your PCT should be positive. There should be withdrawal bleeding. Withdrawal bleeding occurs. Okay. As long as the estrogen levels are normal, there is no, estrogen deficiency, endometrium is also normal, then if we give progesterone challenge test, then withdrawal bleeding should occur. So, PCOS is also out. Your answer is uterine synechia, and very rightly all of you are saying it is Asherman syndrome. And the reason for Asherman syndrome in this particular situation, somebody mentioned Aryan, overzealous curettage, excellent. Okay, maybe over aggressive curettage, overzealous enough, so much so that the basalis layer of the endometrium has been destroyed, right? So, when you say overzealous, there is a meaning to it. The meaning is that you have done it so deeply, so vigorously that the decidua basalis has been destroyed. That basalis layer which is responsible for endometrial regeneration. And that is also the reason, see, one thing leads to the other. That is also the reason why Asherman syndrome happens to occur more likely when curettage is done postpartum. When curettage is done postpartum. Okay. And like you said, why no withdrawal bleeding? Why no withdrawal bleeding, bache? Because on the endometrium, and you know the answer, Vaidehi, you know the answer. Why no withdrawal bleeding? Because there has to be an estrogen acting on the endometrium first. Some estrogen should act on the endometrium first. Endometrium should be healthy and build up. Then after we will get progesterone, then only progesterone will act on the endometrium. Fine. So the answer is in the basics of physiology. Okay? Clear now? Anukriti, I think that would answer your question also, PCOS finding to PCT. I think that would answer your question also, right? So that you don't have to mug up what happens in which test. You remember the concept. The concept is, as long as there's no estrogen deficiency, as long as the endometrium is normal, you know, giving progesterone challenge test will have progesterone withdrawal bleeding. So for example, PCOS, the biggest example is PCOS, where there's no estrogen deficiency in PCOS. The endometrium is normal in PCOS. So withdrawal bleeding occurs in PCOS patients. Okay? Clear? Now, same question. If I had asked you, what is the next investigation that you will do? Best investigation that you would do? How will you confirm the diagnosis? And I give you options like ultrasound pelvis, 3D ultrasound. Okay, let me give you options. I tell you 3D ultrasound, I tell you ultrasound, I tell you hysteroscopy, and I tell you HSG, hysterosalpingography. Think and answer. Very quickly you're answering. 3D, USG, hysteroscopy, HSG. Okay. Now, see, we're still on this way. Yes. HSG. Yes. Hysteroscopy. Some people still doubting that we should do HSG. Okay, we will answer that question. And Spidey has given very nice answer, diagnostic and therapeutic in the same setting. Excellent. Excellent responses. Why TVS pakka? Okay, dekho yaar. Adhesions inside the uterine cavity. 3D USG will not give you much of an information there. Okay, 3D USG will not be able to give much of information there. Okay, so your best answer, if you have suspicion of uterine synechia, if you have suspicion of Asherman syndrome, the best diagnosis, okay, in that clinical context, your next step should be hysteroscopy. Okay, because that would also be very nicely put by you people, that you will be able to diagnose in the same setting, and if needed, hysteroscopic adhesiolysis as a part of treatment would be done in the same sitting, right? So that would be the answer. Okay, and you wouldn't, if your only clinical suspicion is Asherman syndrome, you would not need a laparoscopy. Please judge your answer based on the clinical context. We're still on this clinical context of amenorrhea. HSG, why not HSG? See, the primary reason, the primary indication of doing HSG in obstetrics, when we do HSG? For tubal patency testing. Okay, that is the indication why we do HSG, hysterosalpingography, during infertility workup as a screening for tubal patency testing. Okay, now HSG can pick something extra. HSG could pick up filling defects inside the uterine cavity. HSG could, you know, point towards these uterine abnormalities. It could point towards, Asherman syndrome and stuff like that. But the primary reason we are doing it is for tubal patency testing. So HSG is anyways a screening test. It is not going to help you much in making the diagnosis. Okay. So that's why HSG will not be the answer to such a situation. All right. Let's move on. Next question. 14-year-old girl is brought to the emergency with acute urinary retention. There is an abdominopelvic lump. She has not yet attained menarche. So 14-year-old acute urinary retention, not yet attained menarche. Local examination reveals a bluish bulge at the introitus. What is the most likely diagnosis? Yes, what is the most likely diagnosis? All of you very quick at answering. I think you're not even letting me read the question and you're quickly answering. Very good. This is imperforate hymen. This is the bluish bulge at the introitus. It is imperforate hymen. Okay. Transverse vaginal septum, the local examination would be normal. There would be no bluish bulge. Okay. Fine. All right. And most common location of transverse vaginal septum is also in the upper part, okay. With the MRKH syndrome, what is MRKH syndrome? MRKH syndrome is Mayer-Rokitansky-Kuster-Hauser syndrome. So, this is associated with Mullerian agenesis, okay. In Mullerian agenesis, the uterus is absent. Right. So, there will not be this history suggestive of cryptomenorrhea or anything. This abdominopelvic lump, what is this abdominopelvic lump? This is most likely blood that has collected inside the, vagina, and maybe has collected all the way up, inside the uterus also. It may have collected all the way into the tubes also, hematocolpos, hematometra, hematosalpinx. That is the reason for this abdominopelvic lump. Okay. So, MRKH syndrome is out because in that uterus is absent. What is ovira? Anybody has an idea about ovira? What is ovira? Ovira is obstructed hemivagina with ipsilateral renal agenesis. Obstructed hemivagina with ipsilateral renal agenesis, that is what ovira is. Okay. So, sometimes this is a rare thing, but let me tell you, because since this was in the option, let me tell you, sometimes there can be this, didelphys uterus. Sometimes there can be this didelphys uterus like this, okay. Sometimes there can be a didelphys uterus and there may be a longitudinal vaginal septum, and this septum may be obstructing one side, okay. This septum may be obstructing one side. That is ovira. It is associated with didelphys uterus. It is rare, but if you know what it is, I think that is good enough. No need to go into too much detail. Okay, fine. So, it is a didelphys uterus where there is a longitudinal vaginal septum also, and this longitudinal vaginal septum is obstructing on one side. So, blood can collect here. It can lead to, obstructive symptoms also. That is the thing. And now, extra pointers. Yes. They could have asked you the treatment of imperforate hymen. You people are very rightly answering. The treatment is, for imperforate hymen, what is the treatment? Treatment is cruciate incision. Cruciate incisions over the hymen. Cruciate incision given over the hymen and letting it drain on its own. Now, Misbah Gohar, you are asking what would be the symptoms in ovira? Symptoms in ovira would be, like cryptomenorrhea like, because blood is collecting inside. So, on one side blood is collecting. So, it would be cryptomenorrhea like symptoms would be there, but at the same time menses will also occur. So, there would be, abdominal pain, but primary amenorrhea won't be there, because from the other side menses outflow will occur. So, that kind of mixed kind of a picture would be there. And now Dr. Mahendra and everybody else who is wondering how to attempt such questions, I have a flow chart for you that will help us to recall very quickly. When you have primary amenorrhea, first thing to look in the question, whether the breast development is absent or whether the breast development is present. Okay. The moment you see breast development absent, register in your brain that for some reason estrogen is deficient. Okay. Breast development absent is estrogen is deficient. Breast development present is obviously there is normal amount of estrogen. There is no estrogen deficiency. Okay. The moment you have said there is no estrogen deficiency means that obviously nothing is wrong with the ovaries. Nothing is wrong with the hypothalamus and pituitary because there is no estrogen deficiency. Focus then on the uterus. Okay. If there is history of cryptomenorrhea is hidden menses, cyclical abdominal pain but no menstrual outflow. Uterus is given to you present. If you see a bluish bulge at the introitus, answer is imperforate hymen. If on local examination everything is given normal, most likely answer would be transverse vaginal septum. Okay. If we have a clinical suspicion of transverse vaginal septum, the best investigation would be MRI pelvis. Okay. Fine. Now, breast development present. If they tell you that the uterus is absent or they tell you that there's a blind vaginal pouch, there are two possibilities that you should think about. If they tell you that pubic hair is present, answer is Mullerian agenesis. Okay. And pubic hair absent, answer is androgen insensitivity syndrome. Okay. Fine. All right. So, that is your answer. Okay, we're clear with this? Pratyush Singh, the patient has blue color bulge without attaining menarche because the menses are hidden. They're actually not coming out. That is why that has an imperforate hymen, right? So the menarche, her complaint is that of not attaining menses because outflow of menses is not happening. It is all collecting inside, right? So one of the reasons could be outflow tract abnormalities, right? Got it? Now, next. Important pointers: primary amenorrhea, breast development present, uterus absent, and there is a blind vagina. I told you two situations to differentiate: Mullerian agenesis, complete androgen insensitivity syndrome. Gonads in Mullerian agenesis are ovaries. They are normal ovaries, remember that. Okay. Serum testosterone levels are in the normal female range. Okay. Karyotype in Mullerian agenesis is 46XX. All right. With complete androgen insensitivity syndrome, the gonads are testes. These testes could be located inside the abdomen. They could be located inside the inguinal canal. They may be found underneath the labia. Point is that they are undescended testes. They may be found anywhere. Okay. Serum testosterone levels are in the male range. So, they are elevated. Okay. The karyotype is 46XY. Okay. Now, management differences. Okay. If there is Mullerian agenesis or if there is androgen insensitivity syndrome, whatever it is, the uterus is absent in both. Uterus is absent in both. They are females, okay. We cannot give them a uterus to bleed. So we can really not do anything about having, letting them have their periods. That is not going to be an issue. The issue is going to be that they have a blind vagina. They have, a blind vaginal pouch that may create difficulty in intercourse. So that is going to be their issue, right? So there is no HRT in Mullerian agenesis. Pregnancy is possible by IVF and surrogacy, fine, but yes, they will need, possibly both may need vaginoplasty. Both may need vaginoplasty. So this is true for both. Okay, this is true for both Mullerian agenesis as well as complete androgen insensitivity syndrome. Okay. Now, Maulik, you are saying MRKH and Mullerian agenesis is the same. Okay, I give the question to the floor. Is Mullerian agenesis and MRKH the same? I told you that Mullerian agenesis is a part of MRKH. What is MRKH? Yes. Question open to the floor. What is MRKH? MRKH is MRKH syndrome. My dear friends, it is comprising of Mullerian agenesis, hemivertebrae is the defect that happens, the physical manifestation is scoliosis and renal agenesis. This together makes up the Mayer-Rokitansky-Kuster-Hauser syndrome. Okay. Now, coming back to the chart, this chart is going to help you remember. See, a complete androgen insensitivity syndrome, gonadectomy after pubertal development is complete will be needed, because these gonads are undescended testes. They are at risk of gonadoblastomas and also at risk of germ cell malignancies. So, gonadectomy after pubertal development is complete will need, estrogen containing hormone replacement therapy later after the gonadectomy has been done. Then they will need after that estrogen HRT, and for them adoption is the only option. Okay, fine. Now the next pointer, extra edge, extra pointer. Any additional concern after the diagnosis of Mullerian agenesis has been made? Associated with renal anomalies. Mullerian agenesis could be associated with renal anomalies, so that's additional concern. Complete androgen insensitivity syndrome is an X-linked recessive disorder. It is an X-linked recessive disorder. Other girls in the family could be affected. Other girls in the families could be affected. Okay, actually androgen insensitivity syndrome is actually a disorder where androgen receptors are deficient. No, androgen receptors are deficient. Okay, fine. Now Dipanjan Mukherjee, why after puberty? Because these gonads, you are asking some very interesting questions, but unfortunately, these are questions for the last minute rapid revision. I am very happy to answer all your questions, right? But that just keeps the pace slow. But since I have picked up your question, these testes are actually producing androgens, and those androgens are getting aromatized into estrogen, and that is the reason why they have breast development. No, so that is why after pubertal development is complete, so that they can have their pubertal development, and then we can do it. Okay. Fine. Now, let's have a look at the next scenario. Okay. That's why not immediately gonadectomy in androgen insensitivity syndrome. Okay, I've answered that question. Why not? And pubic hair, वो तो पहले slide में ही बता दिया. Pubic hair, I've already told you the difference. Okay. Now moving on. Primary amenorrhea, last chart for primary amenorrhea. Primary amenorrhea is a topic you people always get confused. They give you scenarios from primary amenorrhea, and then you wonder what happened. Primary amenorrhea is a hot topic for INI, CET and NEET PG. Okay. Now, primary amenorrhea, breast development absent and uterus is present. Yes. Next step. I told you if the breast development is absent, okay, breast development is absent meaning estrogen deficiency. That is what we have registered, right? Look here, breast development absent. This is where we are continuing. Here, breast development absent. The next step is to go for a full hormonal profile, okay? Ideally, we go for a full hormonal profile, checking estradiol levels, FSH, LH, TSH, prolactin, everything, right? But if you have to pick one, pick FSH as the answer. If you have to pick one, let me repeat, pick FSH as the answer. If your FSH levels are high, estrogen deficiency and FSH levels are high, mentioned in the question, it is hypergonadotropic, hypogonadism. Okay, next step is to do a karyotype. Next step is to do a karyotype. Please remember that you will only find with the help of karyotype what kind of gonadal dysgenesis it is. You will be ultimately confirming with a karyotype what kind of gonadal dysgenesis it is. However, in your exams, they can tell you scenarios like this. They will give you permutation combinations from this flowchart. Primary amenorrhea, absent breast development. They will mention short height, streak ovaries, hypoplastic uterus, FSH levels high, something or the other information. Your diagnosis is Turner syndrome. Most commonly it is 45XO. Okay, they tell you tall female, streak gonads they are mentioning, uterus they are saying present. It is Swyer syndrome. Okay, it is Swyer syndrome, 46XY gonadal dysgenesis. Okay, or it could be other types of gonadal dysgenesis. Other types of gonadal dysgenesis could also be there. 46XX gonadal dysgenesis could also be there. So it could be 46XX gonadal dysgenesis also. That is why we need a karyotype to confirm. Okay, now if your FSH levels are low, and they tell you that estrogen is deficient, FSH is low, the diagnosis is hypogonadotropic, hypogonadism. Okay, fine. Then in that situation, we should always rule out CNS tumors also. We should always rule out CNS tumors also. Okay, if they tell you, they will give you permutation combination, primary amenorrhea, breast development absent, FSH low, they may tell you woman is tall, having anosmia. It is Coleman syndrome. Coleman syndrome is the diagnosis. Okay, they may tell you that she is having some space occupying lesion like symptoms. If there is a CNS tumor, they will tell you something, no? They will tell you that you will think of CNS tumor. They will tell you that she is having headache, she is having this bitemporal hemianopia. Okay, so this is how you get you see how your different subjects can get integrated. So they may tell you that she is having FSH levels low and she is having headache complaint also, she is having some vision difficulty also, she is having bitemporal hemianopia also. Then you think about a CNS tumor, and in the context of primary amenorrhea, please, okay, in the context of primary amenorrhea, the most common CNS tumor is craniopharyngioma. Okay, fine. And once we have ruled out everything else, short female, other causes have been ruled out, FSH is in the low normal range, then we think about constitutional. It is mainly a diagnosis of exclusion. Okay, and the ones who are saying Dipangin and collagen prolactinoma in the context of secondary amenorrhea. Okay, same scenario in the context of secondary amenorrhea, reproductive age group woman, the CNS tumor would be prolactinoma. But in the context of primary amenorrhea, the most common CNS tumor is craniopharyngioma. Right? Okay. Fine. Next question. Let's move on. Next question. INI-CET question, PYQ, last examination, the previous examination. A mother has brought a 15-year-old girl to gynae OPD with the concern of pubertal delay. On examination, the breasts are Tanner stage 1. Now, this question created a lot of controversy, I recall, because there was a lot of discrepancy about what happened to the recall. Recall was not correct. You people got bamboozled about what was this whole scenario. Anyways, but we'll break it down. Okay, mother has brought a 15-year-old girl child to the gynae OPD with the concern of pubertal delay. On examination, breasts are Tanner stage 1, pubic hair are absent, bilateral inguinal masses are palpable, and there is a blind vaginal pouch. What could be the most likely possibility? Okay. Now, when you let's just take a little time with this question, and let's understand how with logic, with howsoever much I have told you and howsoever much you know, even with that, trust me, you can eliminate the options. Such questions with primary amenorrheas, and majority of the questions are of INI CET, they are attempted by eliminating options. Okay, fine. So look at this. Breasts are Tanner stage 1. That means the breast development is absent. Okay, breast development is not happening. Pubic hair are also absent. Okay. If breast development is absent, meaning that there is estrogen deficiency. If some estrogen would have been there, some breast development would have occurred. Pubic hair absent. Pubic hair are androgen dependent hair. If pubic hair are not developing, meaning androgens are not acting. You mark my words. I am saying androgens are not acting. Okay. Androgens, maybe they are not getting produced. Bani nahi rahe. Maybe they are not getting produced. Maybe they are getting produced, but they are not acting on the receptors. Maybe receptors are not there. Whatever the reason is there, androgen action is not happening. Agreed? Androgens are not acting. Mark my words. Okay. Now, bilateral inguinal masses are palpable. There is a girl born and brought up as a girl. The moment you see that she is having bilateral inguinal masses, or inguinal gonads are given to you in the question, something gonads are underneath the labia is given to you in the question, these are 99% most likely these are testes. Most likely these are testes. Okay. When they say that there is a blind vaginal pouch, when they say that there is a blind vaginal pouch, if I say that there is a blind vaginal pouch, remember what it means. It means that the cervix is not there. And therefore, it by default means that most likely the uterus is not there. Okay, remember what it means. It means most likely the uterus and cervix is absent. That is what it means. Now, what could be the likely possibility? Mullerian agenesis, uterus is absent, agreed. But pubic hair should be present. Breast development should be present. Gonad should be ovaries. This is not the answer. Okay, fine. So, it could be androgen insensitivity or Swyer syndrome. With Swyer syndrome, the uterus is present. Okay. Now, for somebody who's asking how come Swyer syndrome 46XY gonadal dysgenesis, the uterus is present? Oh God, that is a long answer actually. See, gonads didn't become testes, they became nothing. They became dysgenetic. So, there was a male fetus who never was exposed to androgens. There was a male fetus who did not have this anti-Mullerian hormone, okay, because anti-AMH is coming from the Sertoli cells in the testes. So, there was a male fetus, just karyotype 46XY, but default female genitalia, internal as well as external. That's in short Swyer syndrome. Okay. So, Swyer syndrome, uterus is present, that is out. Now, androgen insensitivity syndrome, the breast development should be present. In complete androgen insensitivity syndrome, the breasts are well developed. So, that is not the answer. The best answer to choose was hypergonadotropic hypogonadism. Okay. So, again it was a rare cause. So, instead of directly asking you about the rare cause, these people from INI CET, they asked you a question like this, which was sort of difficult and tricky, but still could attempt, possibly attemptable. Okay. Right. Fine. So, by elimination, it was hypergonadotropic hypogonadism. So, 46XY, female, born and brought up as female. possibly with 17 alpha hydroxylase deficiency. This enzyme is needed for androgen production. Okay, this enzyme is needed for androgen production. If androgens are not getting produced, estrogens will not get produced, because androgens are always the raw material for estrogen. So they had androgen deficiency, they have estrogen deficiency, they are born and brought up as females, and that was the answer. Okay, now Vaidehi, you know what, Vaidehi, and for the rest of the people, you could add layers and layers to this complex topic. Like you said that uterus should be present in hypergonadotropic hypogonadism. Yes, if it is a 46XX, even 46XX females could have 17 alpha hydroxylase deficiency, then uterus could have been present. So I would suggest you at this last moment, instead of, because again, you can have layers, permutation, combination. The best way to attempt this question is eliminate the options. Like you rightly said, that uterus could be present, but uterus could be present if the karyotype was 46XX. Okay, fine. Vaidehi, we're clear with that? Okay. Can we summarize now? For you people to mug up in the end eventually, in case INI-CET or NEET PG decide to recreate this question. Okay. Why not B? We have already discussed why not B. Swyer syndrome, uterus is present. Swyer syndrome I put in the differential diagnosis on this flowchart where uterus was present. Swyer syndrome I put on the differential diagnosis on this chart where uterus was present. Okay. It's not in this chart. However, let me also summarize it in a different manner so that you are not confused. Let's just break it down. Okay, let's just summarize and break it down for mugging up purposes. Okay, young girl with primary amenorrhea, inguinal mass or labial mass. Okay, the moment you read this, okay, see if the uterus is present, if the pubic hair are present, your diagnosis should be Swyer syndrome. Okay, in all of these situations, the karyotype can be given to you 46XY. These are testes. Okay, this extra information may be provided to you. Uterus is absent, pubic hair is absent. If you have well developed breast, it is complete androgen insensitivity syndrome. Okay. If your breast development is absent, there is no feature of virilization, right? No feature of virilization. It is hypergonadotropic hypogonadism. And one thing I told you, example 17 alpha hydroxylase deficiency. Okay. If virilization is present, this is very interesting. If virilization is present, okay, pubic hair can be a part of their virilization also. Pubic hair plus minus. Pubic hair plus minus. If virilization is present, there are two possibilities. 5 alpha reductase deficiency and partial androgen insensitivity syndrome. These are the two possibilities worth knowing. Okay. If these people from INI-CET or NEET PG, they want you to differentiate between 5 alpha reductase deficiency and partial androgen insensitivity syndrome, they will have to give you more information. Otherwise, it's not possible. Okay. So either they will not put these two options together. If at all they put them together, which I don't think they would, but if they do, they will have to give you some extra information, like with 5 alpha reductase deficiency. With 5 alpha reductase deficiency, serum testosterone is elevated. This ratio, serum DHT and testosterone ratio is elevated, and this ratio is normal in partial androgen insensitivity syndrome. There it is. Okay, I've summarized. I know I have not explained this entirely because there's a lot of explaining to do, and for this I think in the last bit you can read up in the rapid revision lectures. I've covered more deeply in the rapid revision lectures, but for LLR I think this flow chart should suffice. Okay, fine. Clear? We move on. ओके एंड क्लाइनफेल्टर्स बच्चा क्लाइनफेल्टर्स में क्या होगा तो वो पहले तो गर्ल ही नहीं होगी ना इन क्लाइनफेल्टर्स विल बी अ मेल it will not be the clinical context won't be of a young girl with primary amenorrhea, it will be a male with infertility, isn't it, or male with delayed puberty, right? Context, that the context is entirely different. Chalo, next. A young woman is being evaluated for infertility. Okay, let me also tell you another hot topic which I foresee in the upcoming exams is infertility. A young woman is being evaluated for infertility. She has history of severe dyspareunia and dysmenorrhea. On pelvic examination, uterus is retroverted, tender nodularity felt through the posterior vaginal fornix. Transvaginal sonography also shows ovarian mass of about 5 centimeter, image as shown. The CA125 levels are slightly elevated, 90 international units per liter. What is the likely diagnosis? Yes. What is the likely diagnosis? Yes, it is a very straightforward question. But again, whenever you read the stem of the question, especially long questions, try to extract as much out of the stem of the question as much as possible. So presentation as infertility, one thing. Dysmenorrhea, dyspareunia, the classic triad. Okay, the classic triad. Uterus retroverted, tender nodularity, fell through the posterior vaginal fornix. So something is there in the posterior vaginal fornix. Some adhesions, some deposits are there which are pulling the uterus back. You know, they're kind of pulling the uterus, making it retroverted instead. So there's something wrong there. There's some pelvic findings there. Also, there is this ovarian mass of 5 centimeter, which is showing a typical, this is the mass, okay, this is the ovarian mass, this is showing, they could give you the image or they could show that it is having a typical ground glass appearance. Okay, don't get confused with CA125. In the reproductive age group women, CA125 levels of 90 are okayish. Okay, they have to be, let's say, more than 200 international units per liter to become significant in reproductive age group young women. So I'm not too concerned about these CA125 levels, and they can also be elevated in, you know, CA125 levels in reproductive age group women, younger women. They could be elevated in other gynae conditions, you know, like endometriosis, genital tuberculosis, fibroid, you name it, whatever. It could be raised in a lot of conditions, okay. So the diagnosis here is very good, endometriosis. The diagnosis here is very good, most likely a chocolate cyst, okay. It's not a fibroid uterus. Genital tuberculosis could present with infertility, correct, but genital tuberculosis presenting with adnexal masses is not that common. So I will not choose that answer. If they were asking you about dysgerminoma, they would have given you another tumor marker, right? They would have asked you, they would have mentioned tumor marker raised LDH or, you know, placental alkaline phosphatase, some different marker they would have given you. So this is out. So answer is endometriosis. If I asked you in this context only, let's stay in the clinical context, okay. The mass is endometriosis for the reasons that the classic clinical profile, patient presenting with infertility, dyspareunia, dysmenorrhea, and the clinical findings plus the ultrasound is going more in favor of diagnosis of endometriosis rather than the other 3 options. Okay, that is why the answer is endometriosis. Okay, in fibroid there is not an ovarian mass. Fibroid is a benign uterine tumor arising from the myometrium. It is a leiomyoma, right? So here the answer is endometriosis. If I asked you in this clinical context, what is the next best investigation? Tell me. Tell me what would be the next best investigation. Think that there is a clinical profile mentioned. Infertility. Infertility. Next best investigation. Ultrasound has already been done. MRI. MRI pelvis. CT scan. Hysteroscopy. Laparoscopy. What would be the next best investigation? think HSG also. Let's add another option to the list. The gold standard diagnosis. Wow, the gold standard way to diagnose endometriosis. When your clinical suspicion is so strong, है ना? When your clinical suspicion is so strong, then it has to be laparoscopy. The next step should be laparoscopy. Okay, I would get evidence of endometriosis also. Okay, she's infertility patient. If I want to do tubal patency testing, I could do laparoscopic chromoperturbation in the same setting also. Makes sense, right? So it makes sense to go for a laparoscopy, right? And histopath, yes, Moto Ranger, you're right. If I find these deposits of endometriosis, I do a histopath also. Histopath confirmation if I get, very nice. If I don't, it doesn't really matter much, okay? So preferably with histopath confirmation, but it is not always possible and not always necessary. Identify this image. Identify this image. Yes, this is the image from the patient whose scan we have just seen. This is the chocolate cyst. Okay, this is the chocolate cyst. This is endometrioma, endometriotic cyst. Okay, this is the patient with infertility. We had her chocolate cyst, we had seen her endometrioma, right? And please remember, latest point here, when you have a symptomatic patient with chocolate cyst, with endometrioma, or you know, there's a size which is more than or equal to 4 centimeter, generally we are going to prefer cystectomy as the treatment. We prefer cystectomy as the treatment modality. Why? Because this has least chance of recurrence. Least chance of recurrence if we do a cystectomy. So that is what we prefer as the treatment strategy in symptomatic patients or those who have, you know, bigger size also with chocolate cyst or endometrioma. All right. So remember this for image based questions also. Next question. A young woman is being evaluated for infertility. She has regular cycles with dysmenorrhea. On per speculum examination, the cervix is hypertrophied and there is a mucoid discharge. Pelvic examination is unremarkable. Transvaginal sonography shows that the uterus is normal. Bilateral cystic adnexal masses with incomplete septa and cogwheel sign. What is the most likely diagnosis? This is a recent question. What I don't really recall is that whether this question was asked with a clinical context, but keeping it in a clinical context helps us understand better. So maybe I have tweaked the question a little bit. All right. So there is infertility. There is some dysmenorrhea, there is some cervix that is hypertrophy, there's some mucoid discharge on the cervix, right? So you have to think about all of these things together, right? And there are findings of adnexal masses, right? So the context could be of tubal damage, maybe because, and this cervix hypertrophied with mucoid discharge, cervicitis, right? Maybe there is this element of PID, that is why maybe she's having dysmenorrhea. So maybe there is this element of PID there. That would explain the infertility, wouldn't it? It would explain the infertility, wouldn't it? Right? So most likely diagnosis, see, it's not endometrioma. We just saw what endometrioma looked like. So it's not an endometrioma. Okay. PCOS, no, it's not PCOS. With PCOS, you will have polycystic appearance of ovaries. So it's not a dermoid cyst also. We have a classic image of dermoid cyst, which we will see next. This is a hydrosalpinx. So you see here, this is the adnexal cyst. Hydrosalpinx is the damaged tube, mucosa is damaged and it is filled with clear fluid. That's why it is all black inside, because it is filled with clear fluid. And these are the, you know, these adhesions which you can see inside. This is what cogwheel signs looks like. This is what cogwheel sign looks like. And on the right here is an extra image that I have kept so that you can remember that this is what is called as the waist sign. This is the hydrosalpinx with the waist sign. Okay, it's like the waist of a woman, like that, right? So this is the waist sign. There's a septa here. Can you see? So the tube is dilated, filled with fluid. There's septa inside. It can give rise to the cogwheel sign. It can look like this, or it could look like this, which is called as the waist sign. So diagnosis here is hydrosalpinx. All right, fine. Now next question. Sorry, not next question, next images, Dermoid cyst, remember it is also called as mature cystic teratoma, right? So you can see a classic image based questions. This is the gross appearance of dermoid cyst, okay? It is teratoma, it is containing the mature, that is why mature. Remember this word, mature, containing mature elements of all three germ layers, right? So this is the dermoid cyst which has been removed. This is the gross examination, the image on the left. It is filled with, hair or teeth or, cartilage, so arising from all germ layers, okay? Also filled with this cheesy material, that is this sebaceous cheesy material, right? And this protuberance, this solid protuberance, what is this solid protuberance? I'm just marking that X here. The solid protuberance is the Rokitansky protuberance. Okay, so this here image on the right, this is the mass, okay, and this nodule, can you see this hyperechoic, this white appearing nodule? This is the Rokitansky protuberance, and inside what you can see, dashes and dots, white colored, very white, hyperechoic dashes and dots. This is the dash and dots appearance. That is because of the hair, strands of hair inside, okay? And then the second, the other ultrasound image, right, on the right, clue on top of the image. What is this sign? This is the tip of the iceberg sign, tip of the iceberg sign. So this is the ovarian mass, okay? This is the ovarian mass. We are seeing this here, the Rokitansky protuberance, and inside everything is hidden. This is the posterior acoustic shadowing. This is the posterior acoustic shadowing. Behind it everything is hidden. So this is the tip of the iceberg sign, okay? Right. Now, remember some important percentages here. This is bilateral in up to 10% cases, okay. Most common ovarian tumor to undergo torsion also. The cyst is lined by stratified squamous epithelium. Malignant change is very, very rare, extremely rare. It will, if at all it has to occur, it will occur in postmenopausal women. It is almost never it will occur in premenopausal women or young women. But if at all malignant change happen, there is squamous cell cancer. So the stratified squamous epithelium of the capsule of the cyst, lining of the cyst, that develops malignancy, but it itself is benign. So the treatment is cystectomy. The treatment is cystectomy. Okay, even if it is bilateral, the treatment is cystectomy. Okay. Fine. So these are some important pointers regarding dermoid cyst which you must know. Let's move on. Let's have a look at the next question. A 30-year-old sexually active woman came for regular gynae checkup, okay, and is found to have a 6 by 6 centimeter simple ovarian cyst. She is otherwise asymptomatic. What is the management? So on the side is an ultrasound image showing you the image of a simple ovarian cyst, okay. It is anechoic, it is unilocular, okay. So it is most likely benign. It is most likely benign. So tell me, what is the management? Yes. She is otherwise asymptomatic. She's come for a routine checkup. Okay, and please MedLife with Shri Pache always analyze the ultrasound images with the clinical context. They're already telling you that there is an ovarian cyst. So I've kept this image for you to understand that this is the ovarian cyst. They will give you this information. Okay, it has got a smooth outline. Okay, it's completely unilocular, completely anechoic. There are no solid areas. There are no multiloculations. There are no septations. Okay, so most likely this is benign. Most likely this is benign. So best answer is CA125 in young reproductive age group women is not going to be helpful much. Why to go for an ovariectomy, whether laparoscopy, whether laparotomy, no need. The size is also small, she's also asymptomatic. We can observe, okay, we can follow her up by after 3 to 6 months. We can repeat the scan in 3 to 6 months and see if this cyst is decreasing in size or see if this cyst is increasing in size. Shubham Saini, it could be a cyst adenoma. You are right. It could be a follicular cyst. Follicular cyst 6 centimeter could be. I would have to remove it and see to know for sure what exactly it is. For now, I know it is benign. Could be a serous cyst adenoma, benign. Could be a follicular cyst, benign. Most of the follicular cysts, they are going to resolve on their own. Yes. Another point, oral contraceptive pills. Why are we giving oral contraceptive pills here? Oral contraceptive pills are not treatment for follicular cyst. Let me also tell you, oral contraceptive pills do not resolve follicular cysts. Okay, they are often prescribed. They prevent new cyst formation. They prevent new follicular cyst formation. Follicular cyst, as the name suggests, arises and develops from the follicles. A follicle that continues to grow, that becomes a follicular cyst, like that. Okay. So now, oral contraceptive pills, they anyway suppress follicular growth. That is how these contraceptive pills work also. They suppress follicular growth. So they prevent new cyst formation, but they do not resolve follicular cysts that are already there. They are often prescribed to take care of patient's symptoms if there are. So the reason why oral contraceptive pills are generally prescribed to these women is basically maybe to take care of symptoms. If symptomatic, like dysmenorrhea will be resolved, maybe irregular cycles will be resolved, and for contraception benefit. That is the reason why oral contraceptive pills are generally prescribed. Okay, so it is not always necessary to prescribe oral contraceptive pills. Got it? Fine. So answer here is oral contraceptive pills and follow up. Even if oral contraceptive pills would not have been mentioned, follow up would have been the answer. Okay, but since she is sexually active, she will benefit from, she will get the contraceptive advantage also. So that's why they are given together in this option. Okay. Now, let's summarize. Okay, let us summarize. Indications of surgery. Remember this, mug this up. Indications of surgery with ovarian mass in reproductive age group. When the size of the cyst is more than or equal to 8 centimeter. If you see ultrasound features suspicious of malignancy, right? Now, what are going to be the ultrasound features suspicious of malignancy? I just spoke of those ultrasound features, but can just write down here as a star mark. It could be bilaterality, multilocularity, solid areas, evidence of ascites, metastasis, enlarged lymph nodes. Okay, fine, right? So, ultrasound features of malignancy, if they are there, then that is an indication for surgery. And before we go for surgery, if I have suspicion of malignancy, then we perform tumor markers. Then we perform tumor marker profile. Then we perform tumor marker profile. So, who was asking me? There was somebody who was asking me, why not CA125? And then somebody answered, and then the rest of the conversation I'm missing. But yes, somebody did ask, why not CA125? Because of the ultrasound findings, it is pretty clear that it is most likely benign, right? So that's why CA125 and following up with CA125 is irrelevant, okay? CA125 can also be raised during the time of menses in reproductive age group women, so it is not going to be much of help anyways. But yes, if there are ultrasound features of malignancy, we should go for a gynae-oncology referral. We should perform the tumor marker profile and then decide, okay, based on the tumor marker profile, that maybe a cancer surgery will be needed for the particular patient, right? Now, acute abdomen or torsion, then we have to operate. Then we don't have to think about the size. Then irrespective of the size, if there is a complication, then we have to operate. In pregnancy, the indications to operate remain the same. The question is about the timing. The timing is 14 to 16 weeks. Okay, that is the best timing. Not in first trimester. In first trimester, we generally don't touch these adnexal masses in pregnancy. But if torsion is happening in pregnancy because of an adnexal mass, then we have to operate irrespective of period of gestation. Then it is a emergency, surgical emergency. So they have asked this question, you know, they will ask you that there is a woman pregnant with dermoid cyst, with torsion, size they could mention 5 centimeter, 10 centimeter, whatever. Pregnant, torsion, gestation age also does not matter. Then torsion is a surgical emergency. So if torsion, operate irrespective of period of gestation. Okay. Now also see here asymptomatic. Look at the third chart, third box. Asymptomatic unilateral simple cyst, size less than 5 centimeter and normal CA 125 levels. Just at this point, normal CA 125 levels, meaning less than 35 international units per liter. If all of these are there, then only observe in postmenopausal women. Okay. So asymptomatic also, unilateral also, simple cyst also, size less than 5 centimeter also, and normal say 125 levels also. If everything is there, then only observe in postmenopausal women. If anything is abnormal, we have to operate. So postmenopausal symptomatic, postmenopausal bilateral ovarian masses, postmenopausal complex cyst or complex ultrasound suspicious, postmenopausal there is a cyst which is more than 5 centimeter or raise say 125 levels, anything could be abnormal. If any abnormal, operate. Okay. So remember this chart as well. Okay. Now let's build on. Let's build on adnexal masses. They have asked you tricky questions. An 18-year-old girl, see this is from the latest examination. 18-year-old girl presents with abdominopelvic lump, okay, which on ultrasound, on clinical examination, it is very big. It is very big. It is coming out of the pelvis, reaching the abdominal cavity. Abdominopelvic lump, which on ultrasound is found to be a solid cystic ovarian mass. So there it is. It's solid cystic. They're telling you it has solid areas. It's not that simple cyst anymore. Measuring 10 centimeter, the size is also more. What tumor markers would you like to send? First of all, register that this is a profile where tumor markers need to be sent. Register this, that an 18-year-old girl, such a young girl with such a big ovarian mass and with suspicious features on ultrasound, this is one area where tumor markers need to be sent. What would you like to send is the next question. Okay, so yes, CA125 becomes a, see CA125 is actually a marker for epithelial ovarian cancer. Okay, now see, because epithelial ovarian cancer is generally found most commonly in postmenopausal women, that is why in postmenopausal women it makes sense to do the CA125 levels. In younger women, the levels of CA125 alone will not be very informative. If I have a suspicion of cancer, I need these other tumor markers. Why? Because in such an age group, I am thinking about germ cell cancers. They are the most common in women in their first 2 decades of life. Germ cell cancers are the most common type of ovarian cancer. So my tumor profile will be different. What will be my tumor profile? Yes, very good. All of you answering correctly. CA125, alpha fetoprotein, HCG and LDH. CEA and CA19-9. This is a marker for mucinous histology. Mucinous is also epithelial. The mucinous is also epithelial. Okay, it is particularly a marker for mucinous type of epithelial histology. LDH we know is a marker for dysgerminoma. AFP we know is a marker for endodermal sinus tumor, which is also called as yolk sac tumor. HCG here can be a marker for choriocarcinoma of ovary. It will be raised there, right? So making, obviously option C is the best answer. So we have to send the entire tumor profile. Got it? And other marker is, Karthik, you are right. For dysgerminoma, we have other markers also. Placental alkaline phosphatase can be a marker for dysgerminoma also. But dysgerminoma, please remember, will never secrete AFP. Please remember, dysgerminoma will never secrete AFP. Okay. All right. Next question. 28-year-old, and this was a recent question in your INI CET. Okay. And then you think that, again, my main focus, whenever I discuss clinical questions with you, dear friends, see, the point here is that you gain something. What you have to gain is the understanding that clinical questions are very much attemptable. Okay, all you need is a basic understanding. All right. So, like for example, let's have a look at this question. There's a 28-year-old gravid to do para-1 live 1. Let's approach this question with an open mind. Presents with acute abdominal pain. She's pregnant. Okay. She's known case of rheumatic heart disease for which she has gone under mitral valve replacement, this and that. The relevant information is that she's currently on warfarin 3 milligram daily. Okay. A profile has been set. Ultrasound shows a 14-week healthy intrauterine pregnancy with a 6 centimeter left-sided ovarian cyst with a reticular pattern. So the crux of the question here was this, that there was a reticular pattern on ultrasound. Okay, her vitals are stable. What is the next line of management? Yes, what is the next line of management? So one thing is clear, first of all, that they have given you a clinical profile, so that there has to be some relevance to that information that they are providing you. Otherwise, they would not mention all this story that she is on warfarin. Warfarin is an anticoagulant, right? So if there is a patient is on warfarin, you can understand that when patient is on anticoagulation, there can be bleeding tendencies. Agreed with me there? There can be bleeding tendencies. There's a very vascular, tissue in the ovaries that is going to be there in early pregnancy. What is that? That is a corpus luteum. Remember, that is a corpus luteum, which is very vascular. So that corpus luteum, there could be bleeding inside that corpus luteum. Now see, when you mug up one-liner MCQs, I'm sure you have mugged this up. That corpus luteum cyst is the most common cyst to develop hemorrhage or to rupture. I'm sure you have mugged up this one liner. I am damn sure about it. Okay. Now the relevance is here. They converted into a scenario. The scenario could be, I'm telling you, I'll give you another scenario later. Right now scenario is she is pregnant, she has a healthy intrauterine pregnancy, she had a corpus luteum, and now there's some hemorrhage that developed, okay, and that is why she is having a reticular pattern. Reticular pattern, now this is integrating radiology into obstetrics. Reticular pattern means fibrin inside. Collected old blood, fibrin inside will give a reticular pattern. Fact of the matter is that she's stable right now. Why would I want to intervene? She needs to be on warfarin. She is rheumatic heart disease patient. She is otherwise stable. Even if there's some little bleeding that happened into the cyst, maybe it will resolve. Maybe it will just stop, and it's not creating any problem right now. So it doesn't make sense to go for an immediate surgery. CA-125 becomes irrelevant. I'm not even. Malignancy never even crossed my mind, okay. MRI pelvis, unnecessary. Right now, conservative management and follow-up makes sense. So see how we dissected this question. See how we dissected this question, right? So that is the importance of understanding concepts and using whatever information, facts that you may have already mugged up, you already know. But when they are presented to you in a clinical format, you get lost. So do not get lost is my request. You just read with an open mind. Okay. Now, the other situation could be maybe she was not pregnant. The other situation could be she was not pregnant. She was in the second half of her cycle. Corpus luteum forms in the second half of the cycle. No. Corpus luteum forms in the second half of the cycle. Corpus luteum cyst has happened, corpus luteum is persisting. So there may be an adnexal cyst. She may be overdue also. She may be overdue by a couple of days. This is one of the clinical situations we confuse with ectopic pregnancy also. Okay, so profile could be different. So keep that in mind. Remember here one thing. This corpus luteum cyst could be, woman could be pregnant with along with this cyst, women could be non-pregnant also, that doesn't matter. What is important to remember is, as long as the situation is uncomplicated, patient is stable, she can be observed. But yes, of course, if she is unstable, the cyst may have ruptured also, na? Corpus luteum cyst, bleeding inside, then that cyst ruptured, now bleeding inside the peritoneum cavity. So there could be hemoperitoneum. Use logic. If there is significant hemoperitoneum, if there is any signs and symptoms of peritonitis, then what ratification is needed? This is obviously, you have to operate, then this is an emergency. Then this becomes an emergency, then you will have to operate, right? For now, there is no emergency to operate. So remember this general idea, okay? Fine. Now, exploratory laparotomy, laparoscopy will depend how you enter the abdomen. Obviously, if it's an unstable patient, one would prefer a laparotomy, definitely. If it's an unstable patient, okay? Or even if peritonitis is there, one would prefer a laparotomy. Good. Next question. Long question, but I want to put in a point across. Okay, a 25-year-old woman was brought to the emergency room with acute lower abdominal pain for 2 hours. So she is having acute abdomen. There has been a history of waxing and waning pain over the past 1 week. She also complains of multiple episodes of vomiting. There is no diarrhea. Her pulse rate is 100, temperature is mild temperature, blood pressure is 100/70. So more or less she's settled hemodynamically, right? So stable, I can write stable with mild fever. On per abdomen examination, there is tenderness in the right hypogastrium, no guarding or rigidity. Pelvic examination shows a healthy cervix and tender adnexal mass. LMP was 4 weeks ago. Her periods are regular. Ultrasound shows a 10/8/6 centimeter right-sided ovarian mass with whirlpool sign on Doppler. That's your biggest clue. Rest all is story. Serum beta HCG is negative. WBC count is mildly elevated. Hemoglobin is 10. What is the most likely diagnosis? Now tell me, most likely diagnosis. Yes. So somebody is saying adnexal torsion, somebody is saying hemorrhagic corpus luteal cyst. Ho gaya khatam, hemorrhagic corpus luteum cyst we have discussed. The classic presentation, they will mention either reticular this thing, right? And I'll tell you why this is not hemorrhagic corpus luteal cyst also. I'll rule it out for you. That is what you have to do in the question actually. When you're reading through the story of the question, you have to rule it out. All are differential diagnosis. This is a clinical question. A woman presenting, let's just decipher. There is a young reproductive age group woman who's coming with the complaint of abdominal pain. Ectopic is always on my mind. All of these are differential diagnosis. That is why after doing all of this examination, the person has also done serum beta HCG. One has to rule out pregnancy. I rule out ectopic because HCG is negative, okay? Now, why not hemorrhagic corpus luteal cyst? If there was a cyst that is 10/8/6 centimeter and it was a hemorrhagic corpus luteal cyst, it could be. But then classic ultrasound pictures of hemorrhagic corpus luteal cyst are not given. That is why one reason I will not choose this as the answer. Secondly, some symptoms of hypovolemia should definitely be there. Okay, so that is also not there. So I'm not thinking hemorrhagic corpus luteal cyst. Acute abdomen pain, fever, that could also be a case of acute PID. But I'm not saying acute PID because the pelvic examination cervix is healthy. Okay, so I'm not really thinking about acute PID right now. However, acute PID could be a differential diagnosis in this situation also. But best choice answer is adnexal torsion. This is a classical clinical presentation of adnexal torsion. The pointers in favor, this waxing and waning pain over the past 1 week. Okay, what some episode of torsion happened, then untorsion happened, then torsion happened, then untorsion happened, and then there could be a history where some precipitating event. That precipitating event could have been intercourse or lifting some heavy weight when complete torsion happened. And the history of this, there could be slight temperature, there could be mild temperature also in ovarian torsion. Basically what happens with ovarian torsion, with adnexal torsion, is that there is ischemia in the ovaries. No, ischemia will happen, right? So inflammatory mediators are released. That is why some mild temperature, this vomiting and can be there. And no guarding or rigidity is there, so no peritonitis is there, no hemoperitoneum is there. So that is why I'm not choosing this hemorrhagic corpus luteal cyst or acute PID as the answer. The biggest clincher in your diagnosis is whirlpool sign. Okay, whirlpool sign is basically refers to the twisted ovarian vascular pedicle. Jay Vora, you are right. Whirlpool sign is the main giveaway. Had they not told me about whirlpool sign, I would not have known. I could not have told. If they would have not mentioned whirlpool sign, I really couldn't have told. Then my clinical thing could have been that in clinical practice what I would have done is maybe observed her for a while, investigated on the lines of acute PID, and then it would have become a complicated case. Sometimes the diagnosis of adnexal torsion, not sometimes actually, to be very frank, many times the diagnosis of adnexal torsion, we end up doing a diagnostic laparoscopy, patient worsens and there's no resolve, there's no improvement, maybe on initial antibiotics and observation, and then we end up doing a laparoscopy or a laparotomy and end up diagnosing ovarian torsion. Many times it happens like that. The only giveaway in this situation is a whirlpool sign. And Ayush Sharma, guarding rigidity peritonitis is a sign of peritonitis. Ayush, guarding और rigidity peritonitis का feature है. अब peritonitis किस किस कारण से हो सकती है? Peritonitis अगर तो pelvic peritonitis तो infection related हो सकती है, जैसे acute pelvic, acute PID में भी peritonitis हो सकती है. Peritonitis जो है hemoperitoneum की वजह से pelvic peritoneum gets irritated, उससे peritonitis हो सकती है. राइट, पेरिटोनाइटिस जो है वो पेल्विस में पस भर जाए तो पेरिटोनाइटिस उसकी वजह से हो सकती है. राइट, तो पेरिटोनाइटिस नहीं है, इससे हमने बाकी की चीजें थोड़ी सी एक्सक्लूड कर दी. ये हुआ, आई बात समझ में? चलो अब आगे नेक्स्ट, रिमेंबर मैनेजमेंट. एक और लेट्स जस्ट बिल्ड ऑन इट. मैनेजमेंट ऑफ adnexal torsion. Okay, please, it is a surgical emergency, otherwise we'll, ek to obviously ovaries will get necrotic, and imagine all that necrosis happening inside the body, it will spread, this will be a risk for sepsis also. So this is a surgical emergency, resuscitation and urgent surgery. Okay, so basically we have to explore, like the story I was telling you, many times we have to explore. Okay, now that exploration could be laparotomy, it could be laparoscopy. That depends on the clinical profile of the patient. Please remember, laparoscopy will be contraindicated if she is unstable. If there is peritonitis, obviously I will not go for laparoscopy then. So we are starting exploring. Okay, how we enter the abdomen is another matter. What we do inside is a different thing altogether. So what we do inside for the torsion? For the torsion, we go for untwisting first. Untwisting of the ovarian pedicle. Okay. So when we untwist it, the blood flow will resume. So we can save the ovaries by that way. And cystectomy is done if there is a cyst. Cystectomy if there is a cyst also present, because that cyst may have contributed to adnexal torsion. Cyst makes the ovary heavy, and that is why it undergoes torsion. So if there is a cyst there, then cystectomy also. And salpingo-oophorectomy, sacrificing the ovaries, we resort to that if there is tissue necrosis. If there is tissue necrosis, otherwise there's no need. So first we'll start with untwisting of the ovarian pedicle. Okay. All right. Next question. A 45-year-old woman presented with heavy menstrual bleeding and severe congestive dysmenorrhea. On examination, the uterus appears uniformly enlarged to 14-week size. It is tender and adnexa is free. Ultrasound shows the presence of myometrial cyst. What is the most probable diagnosis? Straightforward question. Yes. What is the most probable diagnosis? Straightforward question. Uniformly enlarged uterus can be given as, in the question, can be given as globular, soft to feel. All this extra information could be given to you, right? Generally it is enlarged to 14-week size. Severe congestive dysmenorrhea, that is, all of these are clues in the question. And on ultrasound, myometrial cyst. All of these is favoring the diagnosis of adenomyosis. Very good. Okay. So with leiomyoma, generally what is going to go in favor of leiomyoma? Maybe an irregularly enlarged, firm to feel, non-tender uterus. Okay. Right. And ultrasound will be able to pick up the diagnosis of a fibroid uterus or a leiomyoma as well. Okay. And leiomyomas, they generally don't have pain. They generally not associated with pain. Okay. Clear? Now, I will just add one more question to it. If in the same clinical profile, okay, if in the same clinical profile, I would have asked you, what is the next investigation? Okay. Next best investigation. Okay. And let's say I was giving you options as, let me give you option. Okay. MRI, HSG, hysteroscopy, endometrial aspiration. What would have been your answer? Yes. Think about it and tell me. बच्चे endometriosis तो already rule out हो गया ना. Endometriosis will not cause an enlarged uterus. Endometriosis will not cause an enlarged uterus. Okay, it will come with a different set of profile, maybe adnexal mass, maybe endometriotic is the clinical profile that we discussed earlier in the previous questions. And endometrial hyperplasia is something that I will not know right now. With the information that is provided, the most probable diagnosis is with the information provided is is an adenomyosis, not endometrial hyperplasia. Okay. अब देखो, MRI, HSG, hysteroscopy, endometrial aspiration, same patient. मैं पूछ रही हूँ next best investigation before doing any treatment, and you are telling me let us do HSG. What HSG? Why HSG? HSG is I am telling you, it is essentially a tubal patency test. This is a 45-year-old woman. The context of infertility is not there. The context of heavy menstrual bleeding and severe congestive dysmenorrhea is there. Okay, so HSG makes no sense. Okay, what extra information will MRI give you? MRI is okay. See, I am telling you, in the clinical context where you want to find out whether it is a fibroid, whether it is an adenomyosis, the initial investigation to begin with, the investigation of choice is an ultrasound. Ultrasound most of the times will answer our questions. Ultrasound will tell me if it is a fibroid to be seen there. Ultrasound will give me information like this: myometrial cyst, such a specific finding of adenomyosis, right? And the clinical profile fitting into adenomyosis. Why would I want to do an MRI? What help it is doing? How is it helping me? If the diagnosis would have been uncertain, if she would have been a young woman with adenomyosis, planning for conservative surgical options and this and that, and conservative treatment, maybe I would have wanted to do an MRI just to be sure. Right now doing MRI makes no sense. Hysteroscopy. Hysteroscopy, why do you want to look inside the uterine cavity? It's not like there is some intracavitary lesion that is waiting for me there. So why would I want to go for a hysteroscopy and a test which I will have to admit the patient, and then a costly one at that. Why hysteroscopy? But why endometrial aspiration makes sense? You mug up these things, and that is why I tell you, you mug up these things. Why? Context is not of infertility. Context is heavy menstrual bleeding, severe congestive dysmenorrhea. She is 45-year-old. How are you forgetting that it could be endometrial hyperplasia also? Age more than 40, irregular, heavy menstrual bleeding. Option is also there, endometrial hyperplasia. This is also one of the important differential diagnosis. First part of the question, they had asked you most probable diagnosis. With the information given in the question, I convinced you answer is adenomyosis. You agreed with me. You also told me adenomyosis. I am telling you, considering the age of the woman, endometrial hyperplasia is also a possible differential diagnosis. So I would like to rule it out before I do any treatment in this woman, because it has the potential to change the diagnosis. Don't you think? So it will make sense. I want to rule out endometrial hyperplasia before I do treatment in a patient like this. So then I want to do endometrial aspiration. So this is one investigation which will make sense. Agreed? Because I'll give you another. You read it in textbook also. You mug up all these things. Endometrial hyperplasias, fibroids, adenomyosis. These conditions can often coexist. These conditions can often coexist. If it is endometrial hyperplasia, tell me what is the treatment of choice for atypical endometrial hyperplasia? Tell me. What is the treatment of choice for atypical endometrial hyperplasia? It is hysterectomy. Right? So if I find atypical endometrial hyperplasia, treatment can potentially change. Medical management I will not like to do. If it turns out to be cancer, then management will change. So this is one investigation which has potential to change the management, even if the profile tells me that it is likely adenomyosis. Still there is one investigation which has potential to change the management, and that is endometrial aspiration, and that is what I would like to do next before giving any treatment to this patient. Alright, and I could have asked you directly also, what is the best treatment? Then you would have answered hysterectomy, because that is what you have mugged up. And most of the times your patients with adenomyosis are going to be multiparous. They are going to be, in that age group, they are going to be family complete, multiparous, beyond 40 years. So hysterectomy is a easy bet, easy answer to choose. But this is something just, you have to think about the concept here as well. Now, next question. See, next question. 45-year-old, now you will not miss. Now you will not miss. 45-year-old multiparous is seen with the complaint of heavy menstrual bleeding and irregular cycles for the past 8 months. On clinical examination, uterus is normal in size, mobile, bilateral, fornicis free. So nothing significant on ultrasound. Sorry, nothing significant on clinical examination. You're not thinking anything, basically. Everything is just normal. Ultrasound is also normal. What is the next step in the management? Yes, now next step in the management. Abnormal uterine bleeding pattern, history of irregular cycles are also there. That could be anovulatory pattern of bleeding also, and prolonged history of anovulatory cycles, her age. These are risk factors for endometrial hyperplasia. If the endometrium is hyperplastic, one may find no findings on clinical examination. Problem is in the endometrium, uterus will not be big in size or anything. Ultrasound pelvis, they are also telling you normal. That is the trick that they are playing with you. They are not telling you about the endometrial thickness, but it doesn't matter because of her age. The next step in the management is endometrial aspiration. Okay, because see, hysteroscopy, see, endometrial aspiration is the better answer because it is an office based procedure. Okay, you can do it in the OPD and it will give us the result. It will be good enough to pick up any endometrial hyperplasia or any possibility of cancer. Please remember the indications of endometrial aspiration. Please remember the indications for endometrial aspiration. Very, very important. What are the indications? Age, any abnormal uterine bleeding pattern. If the age of the woman is more than 40, you do endometrial aspiration before starting any treatment. So, before starting hormonal therapy, it is better to do endometrial aspiration. We don't want to miss hyperplasia or cancer. Okay, can be done earlier if multiple risk factors for endometrial cancer are present. Like she could be hypertensive, obese, prolonged history of anovulatory cycles, then you can do it in younger age also. Can be done earlier in younger age also. And ET more than 12 mm in reproductive age group woman. This is also an indication for endometrial aspiration when a woman comes with any abnormal uterine bleeding pattern. Okay, hysteroscopy is generally done when we have, the initial evaluation is not informative and we want to do, as a next step. Or let's say hysteroscopy would be when there is a clinical suspicion, of intracavitary lesion. Now, you tell me, what could be the clinical suspicion of intracavitary lesion? If I'm thinking that there's something inside the cavity which I'm missing on ultrasound, then I would like to preferably go for a hysteroscopy. Like for example, a woman could have intermenstrual bleeding. She could have intermenstrual bleeding, persistent intermenstrual bleeding. Then I would have liked to go for a hysteroscopy, or suspicion of endometrial polyp. Okay, ultrasound showed, let's like this here, TVS showed intracavitary lesion. Okay, feeding vessel sign positive. Then I would have suspected endometrial polyp. Okay, then I would have done a hysteroscopy for diagnosis, right? So then it makes sense. Fine. And Deepak, you're rightly saying endometrial biopsy is done with the Pipel's cannula. And like again, and you're also saying correctly, if you were saying that there was a fibroid polyp, maybe there was a clinical suspicion of a fibroid intracavitary fibroid polyp, then that would also present with intermenstrual bleeding. If I have a TVS report which is showing suspicion of a submucous fibroid, then I would have done for a hysteroscopy. So these would have been the indications for doing a hysteroscopy. Okay, so then it would have made sense. All right, so for now, the clinical findings are not suggestive of any intracavitary lesions. So why subject to hysteroscopy? We can have the information we need from endometrial aspiration also, right? Now, moving on. Please also remember, if you have a woman with postmenopausal bleeding, if you have a woman with postmenopausal bleeding, always start with a perspeculum examination, because in our patients, cervical cancer is the most common cause of postmenopausal bleeding in Indian women. So don't forget the cervix. If you look at the uterine causes, okay, then most common is atrophic endometritis. Worldwide, atrophic endometritis is the most common cause of postmenopausal bleeding. But in India, yes, postmenopausal bleeding, cervical cancer is most common cause. And among the uterine causes, most commonly you have endometritis, and then you can have endometrial hyperplasias, you can have endometrial cancer also, right? So let's go step by step. In postmenopausal bleeding, always do per speculum examination first. If there is a growth on the cervix, you biopsy that growth. If per speculum examination is normal, we can go ahead with the transvaginal sonography. If on transvaginal sonography, the endometrial thickness is less than 4 mm, we can observe. But if endometrial thickness is more than or equal to 4 mm, we have to go for endometrial aspiration, and we have to see if there is any hyperplasia or cancer. Okay. If endometrial aspiration is normal, but the postmenopausal bleeding continues, then we have to go for a hysteroscopy, preferably with curettage. Hysteroscopy preferably with curettage. Okay, fine. So remember this flow chart, very, very important. Okay, so if your postmenopausal bleeding per speculum examination is normal, first of all, you see if there is a growth. Rule out growth on the cervix. Okay, rule out growth on the cervix. Okay. And if that is there, then we have to take a biopsy. If everything is normal, then focus on the uterus. ET less than 4 mm, observe. Okay, there can be a situation where the bleeding continues. Bleeding continues. You observe but bleeding continues, then go for an endometrial aspiration. Cutoff for endometrial sampling in cases of postmenopausal bleeding is ET more than or equal to 4 mm. It's not 12 mm here. In postmenopausal bleeding, the cutoff is 4 mm. So if that's the case, go for endometrial aspiration. If aspiration is also normal but bleeding continues, then we have to go for the gold standard. So this is the gold standard. Hysteroscopy preferably here. This is it. This is the gold standard. Hysteroscopy preferably with curettage. Okay. It's not visible. I'll just change it a little bit. Now, If they were to ask you extra pointers, if they were to ask you what is the investigation of choice for postmenopausal bleeding and you had to choose one, choose between TVS and endometrial aspiration, what would be your answer? Yes. If they had asked you investigation of choice for postmenopausal bleeding and they would have given in the option, you would have been asked to choose between TVS and TVS and endometrial aspiration. What would you have chosen? Aspiration. Very good. Investigation of choice would become endometrial aspiration. Okay, because aspiration, because of focus is in ruling out malignancy and hyperplasia, and that is possible by histopath. Okay, so better answer to choose would be endometrial aspiration. Remember this. All right. Now, let's have a look at the next question. A woman on workup for primary infertility is found to have two intramural fibroids of 4 centimeter and 7 centimeter blocking the tubal ostia. What is the best course of management? Yes. Assisted reproductive techniques, straight away, GnRH analogues, uterine artery embolization, laparoscopic myomectomy. What is the best course of management? Yes. What is the best course of management? D. Very good. The correct answer is option number D. So, they are telling you that the size of the fibroids is big. They are blocking the tubal ostia, meaning that these fibroids are contributing to the infertility. And that is why it is an indication to do surgical management. Why go ahead directly with assisted reproductive techniques? What are assisted reproductive techniques? IVF, right? So unnecessary, no, when the job can be done by a myomectomy, we go for an expensive treatment strategy. What is the use? No use. So this is out. Okay, when the patient is put on GnRH analogues, fibroids can shrink. Okay, but when the patient is on that medication, will she be able to get pregnant? No. So she is having problem of infertility. Why will I want to do this? Uterine artery embolization. The logic of going for uterine artery embolization is that it can possibly shrink the fibroid, because it will, the blood flow to the fibroid will decrease, the uterine artery embolization. But uterine artery embolization is not an option for women who want to get pregnant in the future. Okay, so uterine artery embolization is not an option for those who want future pregnancy. So answer is laparoscopic myomectomy. If they would have said FIGO stage 1 or 0 fibroid, what is FIGO stage 1 or 0? So what is this FIGO stage 1 or 0? If they would have said intracavitary fibroid, or they would have said less than 50% into the myometrium, that means it is a submucosal fibroid, either intracavitary, or they would have said less than 50% into the myometrium, then it would have been hysteroscopic myomectomy. Then it would have been hysteroscopic myomectomy. So remember that as well. That is the last point I am telling you today. Okay, and we will continue the recall and rapid revision tomorrow at 12 p.m. noon. Okay, so this is the last question of the day, or do you want to keep going for another half an hour? Whatever you tell me, I am okay with it. Yes. What does the general consensus of the class say? Should we take it up? Should we take up the rest for tomorrow 12 noon? That is when we are going to start. Okay, and whether I will take some of your questions. You are saying, is fibroid vanish when woman is pregnant? Not necessarily. It will depend if that fibroid is causing problems. Most of the times they don't. Majority of the times they don't even grow in size in pregnancy. They could grow in size in pregnancy, but mostly they don't. If at all there is red degeneration of fibroid happening in pregnancy, it is initially conservative management. So no, not necessary at all to deal with fibroids during pregnancy, case to case basis. All right, we'll take a few questions. All right. Next question. Quickly we will do. Quickly we will do. Push in maximum questions. Quickly. Easy questions coming ahead. Easy questions coming ahead. 28-year-old woman with BMI 35 kg per meter square presents to the infertility clinic. She has irregular cycles, trying to conceive for past 3 hours. Husband semen analysis is normal. Pelvic examination is normal. Hirsutism is there. What is the next step in her management? So she is obese. She could have been normal weight also. The issue is menstrual cycle disturbances, okay, hirsutism. So, what do we see here? Menstrual cycle disturbances, hirsutism, androgen excess features. Remember the Rotterdam's criteria? So, this is PCOS. This is PCOS. So, what do we need to do? We need to, she wants to conceive. That is why she's come to the infertility clinic, right? So, she needs weight reduction, metformin, and ovulation induction by letrozole. So, letrozole is the drug of choice, okay? We can initiate, and gonadotropins are generally second line drugs, all right? Now, finasteride, spironolactone. These are also drugs which are anti-androgenic, but they cannot be given to a woman who is wanting to conceive, not for those wanting to get pregnant. No, 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 no. They are given to those who are not wanting to get pregnant, because they are, and they have to be given with oral contraceptive pills. They are not to be given for those wanting to get pregnant because of their anti-androgenic action. In case the woman gets pregnant, she is trying to conceive and she conceives, a male fetus, then anti-androgenic drugs can cross the placenta and interfere with the male sexual development, okay, of a male fetus, a potentially male fetus. So these are out completely. All right. So remember here, look at this image. Look at this image. This can be an image based identification. When I say ultrasound appearance of polycystic ovaries, okay, then it is more than or equal to 12 follicles. This is according to the original Rotterdam's criteria. Now they have made it 20. Okay, and we count the number of follicles in either ovary and or the ovarian volume is more than 10 ml. So that is the appearance of polycystic appearance of ovaries. It is the number of follicles that is important. Please keep in mind. Okay, see, necklace pattern can be there. Okay, a string of pearls appearance can be there. Stromal hyperplasia can be there. Okay, these are all features that can be there, but they are not a part of diagnostic criteria. Please remember this extra bit as well. Okay, so this more than 12 I am writing, but please remember this is according to the original previous criteria. Now it is 20. So if you have 20, that is the better answer to choose. Now it is more than 20 follicles. Okay, all women lifestyle modification, weight reduction is encouraged whether she wants to get pregnant or doesn't want to get pregnant. Women not wanting to conceive, then the drug of choice is oral contraceptive pills. First line drug for hirsutism is oral contraceptive pills, right? Drug of choice for ovulation induction, letrozole is a better answer to choose than clomiphene citrate. Gonadotropins, I have already told you, they are second line ovulation induction agents in this situation for PCOS, okay? And role of metformin is as an insulin sensitizer. So these are important pointers. that you need to make a note of. Next question. A couple is being evaluated for infertility. Woman is 28 years old. She has regular menstrual cycles. She has history of being treated for PID in the past. Physical examination is normal. She undergoes HSG for testing tubal patency. The image is shown below. What is the most likely diagnosis? Yes, what is the most likely diagnosis? Yes, endometriosis is something that you will not pick up on HSG. Endometriosis we have discussed. I showed you an ultrasound image, I showed you a laparoscopy image. This is not there, period. Okay. Asherman syndrome possibly could have been picked up by filling defects inside the uterus. Okay, somebody in the chat also had said moth-eaten appearance or honeycomb appearance of the uterine cavity. That's also correct. But here you are saying the cavity is normal. This is not the answer. It's either hydrosalpinx or a tubo-ovarian mass. How do you know it's a hydrosalpinx and not a tubo-ovarian mass? Prashant, it is not Asherman syndrome. Here there is here is bilateral distal tubal block. Here what you are seeing is bilateral distal tubal block. That is what you are seeing here in this situation, right? It could be a tubo-ovarian mass, it could be hydrosalpinx. The fact that she's come with infertility, okay, and the clinical examination findings are also normal, right? So it is more likely a hydrosalpinx, okay, it is more likely a hydrosalpinx, and that is your answer. If I would have asked you what would be the next step, what would be the next step? Yes, you want to confirm. You want to confirm the blockage, you want to look at the condition of the fallopian tube. So next step would be laparoscopic chromoperturbation. Laparoscopic chromoperturbation, right? Now our patients of infertility, we generally want to evaluate the uterine cavity also, because with such tubal factor, with the tubal factor, what we are looking at is that eventually we will do IVF, in vitro fertilization for the patient. So next step is laparoscopic chromoperturbation. If in the option they say laparoscopy plus hysteroscopy, pick that as the better answer, preferably with hysteroscopy at the same sitting, so that in the same sitting I can do two things rather than waste the patient's money, OT time and everything, right? So laparoscopic chromoperturbation preferably with hysteroscopy in these circumstances, so that in one sitting only I can act. If for example, if it was a cornual block, then I could have done a hysteroscopic cannulation also. Hysteroscopic cannulation could be attempted. Okay, could be attempted. So keep in mind, okay, it is not difficult. If it is bilateral distal tubal block, if it is cornual block, doesn't matter. You have to do laparoscopic chromoperturbation, and if the option says preferably with hysteroscopy, then choose preferably with hysteroscopy as the answer, or laparoscopy plus hysteroscopy as the answer. It is not a tubo-ovarian mass particularly, because a tubo-ovarian mass should have been felt on physical examination. At least that should have been the case. Hydrosalpinges are generally cystic, and the generally clinical examination findings are often normal. Okay, so tubo-ovarian masses in the context of infertility would be matted tubo-ovarian masses after PID, after genital tuberculosis. So they should have some physical examination findings. That's why I didn't choose this as the answer. Okay. Now, next question. 28-year-old woman being evaluated for infertility. Question is coming with a slight twist. She has come with the HSG report as shown. She has regular cycles with scanty flow over the past 1 year. There are two things here, okay. Her pelvic examination is normal. Husband semen analysis is normal. What would be the preferred next step in the management? See, there is, can you see here, there is bilateral cornual block. There is bilateral cornual block, and also you are seeing a filling defect inside the uterine cavity. I really don't know, looking at the HSG report, what the filling defect is. Looking at the HSG report, you can't comment. This filling defect could be because of adhesions inside. This filling defect could be an endometrial polyp, an intracavitary lesion, a fibroid polyp, a submucous fibroid. I really don't know what it is based on the image itself, but based on the clinical profile, I might have a clue. Because she's having scanty flow, I'm thinking more likely Asherman syndrome, more likely uterine synechia. Should be the cause for her filling defect. So try to analyze these things in that clinical approach. Okay, so there is a Cornwall block, there is something inside the uterine cavity also which is probably troublesome. So what do you want to do next? Excellent, now you get the gist. Yes, you want to do a laparoscopy plus hysteroscopy. One may need an IVF eventually, that's fine, but even when we do in vitro fertilization, the fertilized zygote, the embryo we keep inside the uterus, you want a normal cavity. So even when we go for IVF, we have to evaluate the cavity, right? So why will I think about IVF right now? I first evaluate, okay? And better to choose laparoscopy, hysteroscopy than laparoscopic chromoperturbation alone. And this is exactly the reason why. Okay, so we've put it in the form of a clinical context to help you understand. Now, why can't you proceed directly with treatment? Option number D, ovulation induction plus IUI. Why can't you proceed directly with that? You cannot. Because for intrauterine insemination, before intrauterine insemination, even if you put the semen inside, washed, prepped semen sample inside the uterus has been kept, fertilization still has to happen inside the fallopian tube. So one has to rule out tubal blockage, right? So tubes should be open for IUI, so that is definitely not going to be an option. Okay, so that is definitely not going to be an option. Next question, let's make it the last question of the day. Okay, yes, we'll make this the last question of the day. A 25-year-old sexually active woman has come for a routine gynae checkup. She has no complaints and is looking for contraception. Okay. On examination, she is found to have 2 complete cervices and a longitudinal vaginal septum. While counseling the patient, what will you not advise? You have to tell me the diagnosis. You have to tell me the investigation of choice in general, and then you will tell me what will you not advise. Yes, 25-year-old sexually active woman has come for a routine checkup. She absolutely has no problems in having intercourse, right? She's come looking for contraception actually. She has 2 complete cervices and a longitudinal vaginal septum. Very good. This is didelphys uterus with a longitudinal vaginal septum. And investigation of choice is a 3D USG, 3D transvaginal sonography is the investigation of choice for Mullerian anomalies, right? Now, while counseling the patient, what will you not advise? This is most likely a didelphys uterus, true. Do you necessarily need a laparoscopic confirmation? And do you need a laparoscopic confirmation? Not necessary, no. So, this is also true, not necessary, true. There can be pregnancy complications in the future. True. There could be. Okay. So, one of the pregnancy complications that can happen is recurrent pregnancy losses in the second trimester. Recurrent pregnancy losses in the second trimester could be the pregnancy complication in the future, but we cannot predict who will have those and who won't have those. Unfortunately, we cannot predict. So, there may be pregnancy complications in the future. If they happen in the future, we then can do something about it. All right. Right now, we cannot say that she will need a metroplasty before she plans for surgery. No. This is the false statement. So, you will not advise corrective surgery before planning for pregnancy. So, incidentally diagnosed anomalies, we don't go for treatment. Please keep in mind, incidentally diagnosed anomalies, we don't go for treatment. Clear? So, answer here is option number D. This is something that you will not advise. Okay. Now, let's have a look at these images. Yes, image on the left. Image on the left is showing you what? These are HSG images. They can be asked as questions. Yes. Image on the left is, yes. Can you see here? There is a dip at the fundus. But on HSG image,
HSG image, I can't see the dip on the fundus. I can only guess. So I will say likely this angle is obtuse. This angle is obtuse. You say this is likely bicornuate. Okay, fine. Here, no dip at the fundus. Can you see? But HSG image, I can't see the dip on the fundus. I can only see that the angle is acute. I can only see here. Let's look at this. This is the angle, bigger angle, and this is the angle. See, smaller angle. And this one here is the bigger angle. That's it. So if your angle is acute angle, then this is likely septate. This is likely septate. Okay. So on HSG image, I can only get idea. Gold standard for diagnosis. 3D USG can differentiate. Investigation of choices, 3D USG only, 3D transvaginal sonography. 3D USG can differentiate. But if they ask you gold standard, it is laparoscopy plus hysteroscopy. Laparoscopy plus hysteroscopy. Keep that in mind. Okay. With septate uterus. With septate uterus, extra point, with septate uterus, if you have recurrent pregnancy loss, or you have infertility, what is the treatment of choice? Hysteroscopic septum resection. Hysteroscopic septum resection. And this hysteroscopic septum resection is also preferably done under laparoscopic guidance. So, gold standard for diagnosis, remember laparoscopy plus hysteroscopy, not hysteroscopy alone. Okay. And septate uterus, if it is contributing to recurrent pregnancy loss or infertility, treatment of choice is hysteroscopic septum resection, preferably under laparoscopic guidance. Next slide. Yes, if you have image on the left, they will have to tell you something. Either they will tell you on per speculum examination there are two separate services. Either they will tell you this, or in the image you will see two cannulas. Then this is diadelphys uterus, most likely. Again, I can't say for sure, I am not seeing the fundus. That's why 3D USG is the investigation of choice. It can help diagnose even diadelphys uterus. And yes, gold standard is laparoscopy, hysteroscopy. Gold standard is not necessary to be done all the time. If initial diagnosis is not available, possible, and then you still want to make a diagnosis, then we want to go for gold standard. Image on the right is unicornuate uterus. Unicornuate uterus. You can see the dye going only onto one side. Okay, this is the anomaly most commonly associated with renal anomalies also. Please make a note of that, right? Yes. Okay. So with this, we finish off the discussion for today. We have covered the high yield MCQs. And let me tell you, your amenorrheas, your infertilities, your Mullerian anomalies, and recently this trend on asking questions from cervical cancer, from clinical questions from abnormal uterine bleeding, especially fibroids and adenomyosis, and your conceptual understanding regarding the indications for endometrial aspiration. And postcoital bleeding, postmenopausal bleeding, these are the key important areas that they have been asking questions on, right? So we've covered all that for today's session. These are the high yield MCQs we have done. I would like to tell you that yes, there is more to the revision than just the last minute revision. So there are my rapid revision videos which are going to be there on the Prep Ladder version X, right? So that is going to be a game changer for you people, because again I have tried to incorporate a lot of MCQs even in the rapid revision videos, right? And it is not just going to be plain simple mugging up points, but clinical oriented rapid revision videos. So check out your version X as soon as possible, guys. Version X launch offer. There's a launch offer that is still live with the best price ever. So they're saying that yes, it is a 40% discounted price of 1799. So 17,999 rupees for a validity of it will be valid for 12 months plus an additional 2 months. But this voucher option is going to be valid till 15th of April only. So for the next 2 days, if you were able to, if you take that launch offer up, it is up for grabs till 15th of April. And we are going to meet tomorrow again at 12 noon. Yes, we're going to be meeting again tomorrow afternoon. So if you have any queries, keep your questions ready, because tomorrow is the day that we will sort them out also. And tomorrow we will again see, my rapid revision is always, my rapid revision for tomorrow is going to focus more on obstetrics, and again it is going to be clinically oriented. Okay, I don't doubt that you people know your one-liner pointers. I do not doubt that at all. But yes, I want you to go one step ahead for your upcoming INI, CET and NEET PG, and that's why we are going to see how best we can attempt MCQs with the information that we already have in the last minute. So thank you so much, guys. Me signing off. Bye-bye. Take care. Thank you so much. Thank you so much for your patient listening and your responses. Bye-bye, guys. Take care. Good night. See you tomorrow, 12 noon.